Good evening, esteemed faculty members, speakers, and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with association with AFG. It's my privilege to introduce the convener of today's webinar, Dr. Rajendra Nagarkatti, sir. Sir is currently the Clinical Secretary of AMOGS, immediate past chairperson of FOXY Midlife Management Committee, and also AMOGS Midlife Management Committee, founder secretary of ISOPA Mumbai chapter, president of Obstetric and Gynecology Society of Meera Bhayandar, past president and advisory board member of AFG Mumbai. I welcome you, sir. It's my privilege to introduce the coordinator of today's webinar, Dr. Monica ma'am. Ma'am is currently the consultant obstetrician and gynecologist at Mangalya Nursing Home and
Saiti, that should be fine. Let's
Yes,
get on to the academics.
I welcome you, ma'am, and I hand over the session to you.
Thank you so much. We welcome you to the 7th episode of the AMOGS Emergency Obstetric Committee webinar, held by none other than Dr. Sneha Bhuyar, madam. Madam has been a visionary in organizing these academic programs which have day-to-day practical issues so that each delegate who has joined will be benefited from it. I would like to introduce madam now. Can we have the slide, Sahiti, please? Madam has been...
Monica.
Yes, ma'am.
Prayer song, ma'am.
We just invite
I would request all the esteemed faculty members, our chief guest and guest of honor, to please join us today for the lamp lighting ceremony. With the blessings of Lord Almighty, we will start with this academic session. Thank you so much, Saiti. Ma'am, I request you to please introduce our chief guest and guest of honor for today, sir.
Yes, Saiti, you can stop sharing. A very good evening to one and all. At the outset, let me welcome all of you and have the blessings from all the seniors. Respected seniors and dear friends, myself, Dr. Sneha Bhuyar, AMOGS Chairperson of Emergency Obstetrics Committee, welcome all of you on behalf of AMOGS for this virtual scientific session with AFG. Chief guest for today's program, my mentor, Dr. P.K. Shah sir, and Dr. Rajendra Saragi sir, who will guide us today on surgical management of BPH, and Madam Suchitra Pandit, the past president of FOXY, striving hard always for the women's health, will take us through the prediction and screening test for HDP. I'm sure it will definitely help us in reducing the severity of HDP and the associated morbidity and mortality. I also welcome respected President of AMOGS, Dr. Kiran Kurtakoti, Secretary General, and guest of honor for today's program, Dr. Bipin Pandit sir, immediate past President of AMOGS, Dr. Rajendra Singh Pardesi, Dr. Rajkumar Shah sir, the President of AFG, and Professor Dr. Niranjan Chavan, the Secretary of AFG. We are privileged to have so many past presidents for these prestigious organizations, including Dr. Mohan Kadam, Dr. Manohar Motwani, Dr. Kartikeya Bhagat, Dr. Rakesh Pandya, and our dear friend Dr. Rajendra Nagarkatti, who is the biggest asset for me in the planning and execution of this program. We are also fortunate to have with us our dear friend Dr. Komal Chavan, the FOXY Vice President-elect, and also the other panelists, Dr. Ujjwala Netam, Director of Sun Hospital, Dr. Navneet Desai, Honorary Scientific Secretary of AFG, Dr. Dhaval Belvi, Dr. Kritika Mukhe, Dr. Pranita Bankar, and our dear Dr. Sargam Soni as the esteemed panelists, Dr. Rajendra, Dr. Monica Umbadan, and Dr. Madan Kamble. These are very dear friends who have worked very hard for this entire program, and they have definitely helped me in the execution of this program also. Now I take this privilege to invite my mentor and today's chief guest, respected Dr. P.K. Shah sir. I'm sure I will not spend much time in reading his CV, rather than I would prefer to listen to his precious words. I just hand over to you, sir, and eagerly we welcome you and have your blessings also.
Thank you,
Over
Sneha. Thank you very much for inviting me to this AMOGS Emergency Obstetric Committee in association with Association of Fellow Gynecologists. I think this is the 7th episode, and I thank office bearers of AMOGS and Dr. Sneha Buyar, who is the chairperson of AMOGS Emergency Obstetric Committee. It's nice to share this platform with fabulous teacher like Dr. Rajendra Saraugi and my good friends who are going to be with us as guests of honor, Dr. Rajkumar Shah, Dr. Niranjan Chauhan, and Dr. Vipin Pandit. As Sneha said, that we have picked up today fabulous topics like surgical management of PPH, which is going to be managed by Dr. Saraugi, and screening or rather prediction and prevention of HDP, hypertensive disease of pregnancy, by Dr. Suchitra Pandit. It's a star-studded program, let me tell you. I have not seen so far so many known people in any of the webinars so far. So I really congratulate you, Sneha, for bringing all these people together. Then we have a panel which is going to be moderated by Dr. Sneha Buyar herself and Dr. Raju Nagarkatti on near-miss case-based discussion. Also, it is so nice to see chairpersons like who are all our friends, like Dr. Komal Chauhan, Dr. Manohar Motwani, Dr. Mohan Gadam, Dr. Karthikeya Bhagat. I think you've been working, Sneha, for the last so many years, and it's a dedicated, you are dedicated to obstetrics and gynecology, and we would love to have you in Foxy as vice president. I wish you success, compelling success in the forthcoming election of Foxy for the vice president's post 2024. As we have such superb topics selected, I won't waste time, and I wish you all the very best for all your future programs and your future endeavors. Thank you very much for having me for this webinar. Thanks a lot.
Thank you, sir. Thank you so much, respected sir, for your support, encouragement, appreciation, and your blessings always. Thank you so much. Saiti, can we have Sir Rajendra Saraugi's CV? Such a illustrious personality, teacher of teachers, and I was never your student, sir, but like Eklavya, I've been learning from you. So it's my privilege to have you as chief guest today and also as a speaker. So I'm sure everybody knows you so well. You were the ex-honorary professor of St. G.S. Medical College and ex-honorary and HOD of R.N. Cooper Hospital, Mumbai, a senior consultant of none of the and so many. Yes, definitely. I'm not going to read. In fact, we would love to listen to you, sir. Over to you for your precious words, sir.
Thanks, Sneha. First and foremost, I would like to thank Sneha Buyar, Emergency Obstetric Committee's chairperson, AMOGS, our own AFG President, Dr. Rajkumar Shah, and your entire committee for inviting me as a chief guest, as well as to give a talk on surgical management of PPH. Let me tell you, your committee is a wonderful committee and it has really good role to play as far as India is concerned. That maternal mortality in India has declined over the years to 97 in 2018-20 And now it has come down to almost, in Maharashtra, it has come down to 34. Though we are still lagging behind Kerala, which is 33 per lakh. So it's a huge task for you. In association with AFG, I am sure even Rajkumar will be able to help you out along with all of us. And we will strive to make it less than 30 or maybe less than 25 over next 2 or 3 years. Though maternal mortality is maximum in Assam, almost 230. So my suggestion to you all will be visiting Assam and trying to help those ladies over there and the gynecologists over there how to help in declining the maternal mortality. Today's talks are excellent talks, excellent panel discussion. See, we have maximum mortality due to either PPH, anemia, and hypertensive disorders of pregnancy. I think PPH and anemia go hand in hand. And we have Suchitra giving us talk on hypertensive disorders of pregnancy. I think we are going to make it a big success, and all the best for your future endeavor. Thank you.
Thank you, sir. Thank you so much. In fact, your message very well taken, sir. Last week itself, we have had a virtual program on with Northeast societies, and Dr. Sheila Mane spoke on the medical management, and Dr. Mahesh Gupta on the surgical management of PPH. And we moderated a panel on, the hypertensive disorders of pregnancy. So it was very good. In fact, the experience sharing. I'm sure we will try something beyond this, and I promise you that we'll work very hard to reduce the maternal mortality. Thank you so much, sir. And now I invite the guest of honors, Dr. Rajkumar Shah, sir, who is the president of AFG, senior consultant gynecologist at Nanavati Hospital, and so many accolades, and of course post he has held. So we would like to hear from you, Dr. Rajkumar Shah, sir. Over to you for your words of guidance.
Good evening, friends. It's my pleasure. Am I audible? It's my pleasure to be associated on emergency obstetric care. We have two lovely talks by Dr. Saraugi and Suchitra, who's a personal friend. They will be doing definitely justice to the topic, no question. Besides that, we have a wonderful panel discussion which has been planned, and really interesting cases that have been presented. So our wholehearted support is there to you, Dr. Sneha Bhuyar, for your efforts for performing such programs, and also for your future pursuits for the Vice President's post. So all the best, and let's go ahead with the program. Thank you.
Thank you so much, sir. Thank you so much. Now, may I invite Dr. Bipin Pandit, sir, who is the guest of honor for today's program, and also the Secretary General for AMOGS, for your precious words, sir. I'm sure all of you know very well that sir is an immediate past Vice President of FOXI, and of course the past Executive Council member of MMC as well, President of MOGS as well. So we are eager to listen to your words of guidance.
Thank you very much, Neha, for inviting me on behalf of AMOGS and AFG. Of course, I'm involved in both the associations. I would like to welcome everybody there. And it's a great pleasure to be here for an interesting topic like this. Dr. P.K. Shah, our past president of FOXI, Dr. Suchitra Pandit, again past president. Everybody's teacher, Dr. Sarogi. When we think of obstetric emergencies in Mumbai suburb, the only name comes in front of us in panic is Dr. Sarogi. And he's always there to help us, eager to help us at any time of the night or day. And we have to learn a lot from him, his surgical skills, his knowledge, and his teaching experience. And of course, this seminar will be a great help to everybody. Of course, Dr. Motwani, my very good friend, Dr. Rajkumar Shah, president of AFG, and all other luminaries are here. And I'm sure this is going to be very interesting. And thank you very much, Sneha Bhuyar, for all the work you are doing on this important topic, and all the best for your election for Vice President. Thank you very much.
Thank you. Thank you so much, Bipin sir, for that. Your best wishes definitely, and of course, your support will definitely take me a long way. Thank you so much. Can we have Dr. Niranjan Chauhan, CV? So, Professor Dr. Niranjan Chauhan, who is the professor and unit head of LTMMC and LTMGH Sion Hospital, joint treasurer of FOXI at present and secretary of AFG, as I have already introduced him. Past president
Thank
of
you.
AMOGS. Yes, we are eager to listen to you, Dr. Niranjan.
Thank you.
Over to you for your precious words.
Yeah, so it's an honor and privilege to be here today as a guest of honor. I am probably the smallest of all in all the doyens which I see here in presence. What can I say about the Bhishma Pitama, Dr. P.K. Shah sir, which I worked, and then the other Bhishma Pitama from the western suburb, AFG, Dr. Rajendra Sarogi. So I've been lucky to be born in the western suburb, but my Karma Bhumi is Sion Hospital, which is in the central suburb. So I got, sandwiched between the Eastern Express Highway and the Western Express Highway. And both of the, organizations, we are such a wonderful, people where we adore our teachers, where we adore our students and the colleagues which we are there. We are always selflessly rather, go out of the way, not only in helping and assisting and knowing and giving the knowledge, but also during emergency time. And that's what AFG stands for. To briefly give you an idea, of course, AMOGS is the 44, societies membership, which has been founded long time back. AFG was founded in 2000 with Dr. C.N. Purandare, Dr. Daftari, and Dr. Sarogi sir being there at the helm of affairs. And now it has become a big body extending. And I'm sure more and more members will be joining. And what can you ask for today? Dr. Sneha Bhuyar, none other than Dr. Sarogi sir talking on his favorite topic, and our Suchitra Pandit madam, who is also a great exponent and a lot of knowledge she has about pregnancy-induced hypertension, and the panel discussion with all the luminaries which you have. I wish you all the best for your success in the future, and let's start the ball rolling without much ado. And I hand over the mic to you. Take care.
Thank you so much, Dr. Niranjan, for everything, I would say. Thank you so much. And I just, formally thank all the luminaries here, and thank you so much for your blessings. And we declare that the program is inaugurated. And without much ado, we go ahead with the academic session. And for this, I hand over the session to Dr. Monica and Dr. Madan Kam.
Madan sir, can you please take over?
Yes. Good evening, all. Now we will move to the first session of this webinar. We have got the eminent chairpersons for this session, Dr. Manohar Motwani sir and Dr. Komal Chauhan ma'am. It's my privilege to introduce Dr. Manohar Motwani sir. He is the practicing OBGYN specialist for more than 35 years in Mumbai. And he is the head of OBGYN department at Rajawadi Hospital. And he is the director of Karbhari Nursing Home and consultant at Surya Hospital, also past president of Association of Fellow Gynecologists. I welcome you, sir. May I have Komal ma'am? Actually, she doesn't need any introduction. Actually, she is current vice president of FOXI. She is very active FOXian. I welcome ma'am for this session, and I request Dr. Manohar sir to introduce our speaker, Dr. Rajendra Sarogi sir.
Thank you. Actually, before sir introduces the speaker, I would just like to thank Dr. Madan. And I just want to complete that I am a proud AFGite today and also part of AMOGS. So FOXI is there, it is there, AMOGS is FOXI, but I am also belong to AFG, and for AFG, we are always there. And thank you so much with all teachers and everything. It is my honor to share talk of my teacher, Dr. Sarogi, whom we have learned the nitty-gritties of OBGYN. And I have my OBGYN journey has begun with Sion Hospital with Dr. P.K. Shah. So I'm really blessed today. And sir, over to you, Dr. Manohar Motwani, sir, whom I always adore. You can go ahead and introduce, sir. We are all eagerly waiting to hear, sir.
Yeah, I'll speak the minimum I can. But when it comes to Dr. Sarogi, you just can't speak less. That's the kind of a person he is, you know. Anyway, friends, good evening to all of you. I'll make it short and sweet. Dr. Sarogi is a veteran. You know, he's a legend. I, in fact, look up to him in such a big way. He's among the most respected and looked up by me because he's made such a lasting influence in my career ever since I got to know him from the late 90s or perhaps the early 90s. Until now, he's been a mentor with me for so many years. Come what may, if there's any difficult case or something, the sir is most eager to give you a helping hand and coming to your rescue in most difficult situations. Well, sir, if you look at the CV of sir, you won't find him being a president of many societies, not even MOGS, neither in Foxy. And I sometimes really wonder why not, because he never chased societies. He chased teaching. He chased around the place, just wants to get the students getting the best of him. And he's learned so much from his teachers. And one teacher we can never forget was Dr. Rawal, because you always make a mention of late Dr. Rawal when I was with him at Cooper Hospital. His major two contributions to students has been the formation of AFG and consultants, of course, formation of AFG and its little baby called the RAN Symposium, which is really growing leaps and bounds in the last few years, or maybe more than 10 to 12 years. Because it was the thought process of his which came forward to say, let's give back to students, let's give back to the society, and we came out with his RAN Symposium. Well, coming to think of it, he's just not the best OBGYN person I know when it comes to surgery, but when it comes to organizing workshops, you can't have a workshop in Mumbai without Dr. R.M. Sarogi and, of course, Dr. Gadam being there. Let me tell you, he has been roped in by Foxy for the AICOG 2025 workshop also. So he'll be a part of that workshop. Coming to that, I just remember two things of him in Hindi when he comes with a difficult situation. When you ask him, sir, ये कैसा होगा? इसको कैसे करना? He says, हो जाएगा, कर देंगे, कोई problem नहीं है. Any surgery, name it. But one thing I think which he opted out was the IVF thing, which he handed over to his son, Mohit Sarogi, who's doing extremely well. So this part of my CV may be a little different, not the ones which you give it on the slide, sir. But it's a pleasure to listen to you on your topic. And I don't think any workshop of AFG has ever been completed without a surgery on surgical aspects of PPH. And who none other than Dr. Sarogi can do justice to this topic. Sir, it's all yours without encroaching into your time. Thank you very much. And again, I thank AMOGS and Dr. Sneha Bhuyar and Raju Nagarkati to give me this opportunity to be a part of this program and share sir's session. Thank you.
Thank you, Manohar. Monica, can I have my first slide, please?
Yes, sir.
Yeah, next, please. I'll be talking on surgical management of PPH. This is an old slide. Globally, maternal death occur every minute. Hemorrhage accounts for 30%, anemia also 19%. So almost 50% of the deaths occur due to hemorrhage or anemia. Annually, 55,000 women die due to pregnancy-related causes in India. Luckily, with good help from Foxy, MOGS and other organizations, our MMR rate has come down in India now. Next.
Yes, sir.
Let's try and understand PPH can be divided into two parts. One is third stage hemorrhage, that means bleeding before expulsion from placenta. And second is true PPH after expulsion of the placenta. So we'll concentrate on both of them. I'll try to go a little fast because I have many slides. Next, please. Primary PPH, as you all know, is blood loss of 500 ml or more within 24 hours of delivery. And secondary PPH is significant blood loss between 24 hours and 12 weeks after birth. Mind you, 12 weeks is the most important thing. But this definition is also not very accurate. Again, classification of PPH, why it's important for us to know is, depending on the severity of the blood loss, we'll have to transfuse the blood. It can be minor 500 to 1000, moderate 1000 to 2000, severe more than 2000, and major is more than 2500. And there is another terminology called as massive. loss of 1 blood volume in 24 hours, or transfusion of more than 10 units within 24 hours. Next. Causes we all know are tone, trauma, tissue, thrombin. Next. Retained product of conception accounts for 10% of all the cases of PPH. I'll not go into detail about these. Next. Genital tract trauma accounts for almost 20% of all the PPH causes, which can be tear, laceration of vagina, perineum, cervix, extension of caesarean scar, uterine rupture, inversion, vulval hematoma, and broad ligament hematoma. Next. I'm not talking about primary PPH right now because that accounts for almost 70% of all the cases and 5% comes in coagulopathy. Secondary PPH is products of conception, retained placental tissue and membranes. It can be endometritis. It can be placental site trophoblastic tumor like gestational trophoblastic tumors. AV malformation, that is pseudoaneurysm of uterine artery, and sloughing of caesarean scar. How do you judge how much blood loss is there? We have various indices for that. Shock index, that means heart rate divided by systolic BP. Normal is 0.5 to 0.7. But if it is more than 1, it suggests severe hemorrhage. Why I'm trying to show all these things is, these are bedside measures to find out how much is the blood loss. Second is rule of 30. If systolic BP falls by 30, heart rate rises by 30 beats per minute, respiratory rate rises by 30 cycles per minute, HB falls by 30%, urine output falls by 30 ml per hour. It's a case of moderate to severe shock with more than 30% blood loss. Next. These are the various degrees of shock. You will find tachycardia occurring everywhere. So what I have done is, if you find palpitation, patient talks about palpitation, it's normal BP, 10 to 15% loss, and patient will be compensated. If patient is sweating, it's a mild degree of shock, and the loss is 15 to 25%. If patient is restless, then it's a moderate degree of shock, and the loss is 25 to 35%. And if patient collapses or there is air hunger, it's a severe type of shock with blood loss of more than 35%. See, these are all bedside measures. Now, how do you manage such cases? First and foremost, try and find out, has the placenta delivered and is it complete? Really, we don't bother. Once the baby is out, we leave it to the nurse to deliver the placenta and check the placenta whether it's a complete placenta or not. No. Ideally, you should check the placenta whether it's complete or not. Is the uterus well contracted and retracted? And is the bleeding due to trauma? Next. Now, this is very important slide. We generally have a tendency to use black colored or pink colored IV cannula. This slide will give you an idea. If it's an orange colored cannula, it's G14. If it's a gray, it is G16. Green is G18. Pink is G20. Blue is G22. And lime is G24. If you look at the flow rate, when you use orange or G14, the flow rate is 300 ml per minute. If you use gray, it is 172 ml per minute. When you use green, it is 76 ml per minute. When you use pink, it's 54 ml per minute. Blue, it is 31 ml per minute, and lime is 14 ml per minute. Now, remember one thing, any patient coming in labor, your idea should be to start IV with gray or green. You may not be able to get orange, but gray or green should be the one which should, with the IV should be started. Remember one more principle in life. If the patient collapses, you will not be able to start IV even with a blue line. So before patient collapses, or when the patient comes in labor, or when patient is induced, always start an IV with gray or green line. Another thing about drip set. Jaldi mein you tell sister to get a drip set and she gets a micro drip set. The flow of fluid through micro drip set is 60 drops is equal to 1 ml. while macro drip set, it's 20 drops per 1 ml. So always keep in mind to ask her to give a macro drip set, not the micro drip set. Now let's come to the specific management. I'll not go into detail about medical. I'll talk about surgical and interventional radiology. Next. What is the FIGO recommendation for treatment of PPH when women are waiting transfer? Do bimanual uterine compression, which is very easy and it's a bedside procedure. You can do external aortic compression and use of MUST, non-pneumatic anti-shock garments, which we'll discuss little later. Next. Now, this is something which I read in recent Advances in Obstetric and Gynecology, Volume 4. This was by Professor S. Arul Kumaran. If uterine atony is suspected, give ergometrin 0.5 milligram IV. Start an infusion of 100 units of syntocinon with 0.5 milligram of ergometrin in 500 ml of normal saline at 90 drops per minute. If no response in 10 minutes, start another drip with 300 units of syntocinon and 0.5 milligram back, please. 0.5 milligram of ergometrin in 500 ml of normal saline at 90 drops per minute. Why I have included this slide is we have tried this method and we have saved more than 25 uteri at Cooper Hospital. So don't be under the impression that by using extra syntocinon, generally in our books, WHO recommends 10 units or 20 units, but here we have used up to 300 units to 400 units also. So don't be scared to use syntocinon. Even if the urine output drops, it's question of just 2 to 3 hours before you realize that bleeding has stopped and you can switch over to other methods. Next. This is how you can do bimanual compression of the uterus. It's very simple procedure and it's easily done, particularly in a thin, lean patient. It's very, very easy to compress the uterus and you'll find the bleeding stops. Next. Aortic pressure is a crude method and the force required is almost 41 kgs. In fact, in a thin, lean patient, if you put your hand over the epigastric region, you'll be able to feel the pulsations of the aorta. Uterine packing, it's a controversial, good if done along with internal like artery ligation. Next. This is uterine packing plastic bag infused with saline. Next. Uterine balloon tamponade can be done with Sengstaken's Blackmore tube, Bakri balloon tamponade or Shivka's pack. Shivka's pack we have tried and it's very useful. In fact, I had a video, but it's not possible to demonstrate here right now. Next. This is how Bakri balloon tamponade works. Next. Military anti-shock trousers, inflatable pneumatic suit to envelop legs and abdomen, controls hypotension, improves perfusion of vital organs, slows bleeding. Basically, this is useful when you want to shift the patient or transfer the patient to a bigger institute where you want blood supply to go to the vital organs rather than going to the extremities. So this is how it works. Next slide, it will show you the picture. This is how it works, you know. It raises the pressure towards central area. That means kidney, liver, brain, heart, lungs will get more blood supply as compared to the periphery. Next. Uterine compression sutures. I want to elaborate on these methods now. Remember one thing, you can have two conditions. One is at the time of cesarean section, you realize that patient has uterine atony. And second condition is at the time of normal delivery, you realize that patient has atony. In both cases, the sutures will differ. At the time of cesarean section, you can have B-link suture. While at the time of normal delivery, or if you have done a Caesar and you have already closed the lower segment cesarean wound, and you realize that she requires compression sutures, you can go ahead with Heyman sutures. In B-link suture, it involves a lower uterine incision to check for emptiness of the cavity Brace sutures to uterus without transfixing anterior and posterior uterine walls. Next. See, this is how it is being taken. Now, what B. Lynch advocated was 3 or 4 centimeter. I have been advocating 4 to 5 centimeters, 4 to 5 millimeters away from the wound. That means from lower segment, you can start with 50 mm needle. There are 50 mm needles available. You start with 50 mm needle, 5 millimeter away from the lateral border. Take a suture, go through the upper border, go around, come posteriorly near the uterosacral attachment, come inside, go on the opposite side, come out again, and come from above on the right side of the patient and bring the needle. Now, before doing any of the compression suture, remember one simple principle, and that is you try compression test. That means compress the uterus and see if the bleeding has stopped, because it's basically meant for uterine atonic uterus. So when you compress the uterus and bleeding stops, that means your compression sutures are going to be beneficial. Here you can see the picture BC showing you how the compression of the uterus will occur. And once the bleeding stops, you close the uterine incision wound. So basically, B-Lynch suture is meant when at the time of cesarean section, when the wound is open, that's the time you do it. Next. This is how it looks. You suture it down. Here they are mentioning 3 centimeter. I take almost 4 centimeter, not 3 centimeter. Next. This is how the picture looks. This we did in one of our cases and we took the picture. Next. Heyman suture. 2 vertical sutures are placed over the fundus, effectively sewing the anterior and posterior walls together, and 1 cervicoischemic suture anteroposteriorly. Now, this suture is basically meant if a patient has delivered normally and it's unscarred uterus. You have opened up the patient to do such surgeries. In that case, you take a suture directly, or at the time of cesarean when you have already closed the lower segment and you realize that atonicity of the uterus is persistent, you can go ahead with Heyman suture. Next. This is how Heyman sutures are taken. Go from anterior to posterior and tie it on top on both the sides. You can have 3, 4, 5 ligatures also on top of the uterus. Again, the compression test has to be done. Next. This is how Heyman suture will look like. You can see the knot on top of the fundus and suture going from anterior to posterior, and just tie it on top of the fundus. Next. Mind you, there are so many types of sutures which can be done. Basic idea is to approximate the anterior and posterior wall of the uterus where the bleeding occurs. So tomorrow you can have Snehas, you can have Bipin Pandits, you can have PK Shah sutures also. I'll show you quite a few sutures now. Cho sutures are multiple square sutures to approximate anterior and posterior uterine wall, especially in areas of heavy bleeding. Next slide, please. See, this is how Cho sutures you can see. 4 of them have been put. Basically, you have to look for the area of bleeding and you go from anterior directly posterior, make a square and come out anteriorly and tie it. These are the areas from where the bleeding was occurring, and you can have Cho sutures like this. Next, please. Pereira suture. Multiple sutures opposed longitudinally and transversely around uterus. Now, mind you, all these earlier sutures were going through and through the uterine cavity, while Pereira suture is placement of the suture involves a series of bites inserted superficially, taking only the serous membrane and subserous myometrium without penetrating the uterine cavity. Can we have the picture, please? Next one. This is how Pereira sutures are being taken. You can take transversely, vertically, You can see 3 of them being taken transversely and 2 of them vertically. Here we don't penetrate the uterine cavity at all. Next, please. Hecthel sutures, uterine compression using 6 to 16, horizontal interrupted U sutures. As I told you, you can have your own sutures also. Here you can see transversely 1, 2, 3 in upper segment, again 1, 2, 3, 1, 2, 3, again 2. You can see so many of them being poured. So this is Hecthel suture. This is how the uterus looks like after making Hecthel suture. These are U-shaped sutures. That means going from anterior to posterior and tying them. Next, please. This is how the uterus looks like. Next, please. Cunningham sutures, transverse compressible sutures of severe postpartum hemorrhage. Uterus is compressed with tying of transverse imbricating sutures. Here you can see they are being imbricated transversely, and then you tie them. This becomes Cunningham sutures. Next, please. Quaba sutures, 4 sutures placed on uterus with 1 transverse suture in middle of the fundus, 1 transverse suture in the lower segment, 1 on each horn. Next slide, please. Here you can see 4 of them being put, 2 at the cornu and 2 or 3 down. This becomes Cobber's technique. See, as I told you, you can have your own method of putting sutures, and you can come out with your own method. Basic idea is to approximate anterior and posterior uterine wall where the bleeding is occurring. Next, please. Nelson suture sandwich technique with concomitant use of Bakri balloon and B-Lynch. So here you can use Bakri balloon as well as do B-Lynch, and this becomes Nelson sutures. Next, please. Now let's come to stepwise this devascularization. Here you can see there are arrows which have been put. Four places you can have devascularization. We know the uterine artery, once it comes at the level of internal os, it divides into ascending branch and the descending branch. Descending branch will be ligated, particularly in cases where you suspect there is problem in the lower segment. That means in cases of placenta previa, accreta, increta, percreta. While ascending branch is ligated basically in cases of atonic PPH. Next, please. Internal-like artery ligation, conditions indicating ligation, atonic uterus refractory to other measures, abruptio placenta with uterine atony, abdominal pregnancy with pelvic implantation of the placenta and placenta accreta. Next, please. Here you can see aorta dividing into common iliac, right and left, and then common iliac dividing into internal iliac and external iliac. And internal iliac immediately gives out posterior division of internal iliac branch, while anterior division continues further down, and that is where you have to ligate the internal iliac artery. Don't ligate it before posterior division is giving out, because the anastomosis will occur and posterior division has a lumbar artery which anastomosis with iliolumbar of the aorta. So better to ligate beyond posterior division rather than anterior internal iliac and total internal iliac. Next, please. Next, please. How does it work? It controls bleeding by converting arterial system pulse pressure by 85% into venous system if bilaterally ligated. Unilateral ligation decreases pulse pressure by 77%. Blood flow distal to the point of ligation is decreased by only 48%, thus reproductive function is preserved. Collaterals open up within 7 to 8 minutes and blood flow is completely established in 45 minutes. What is more important is we forget one thing. We have a tendency to do either unilateral, particularly on the right side, or bilateral internal iliac artery ligation. We forget that it converts it into a venous system. by reducing the pulse pressure. Now, anything which is converted into a venous system, if you put a compression against that venous system, the clotting will occur faster. So ideal thing is whenever you do internal ligation in a case of atonic PPH is to pack the uterine cavity. Once you pack the uterine cavity along with internal ligation, the efficacy increases by almost 95% in all the cases, which we have hardly seen being done. That is why when I talked about uterine packing, I mentioned that we'll discuss it later. It should be a part of internal ligation whenever you do unilateral or bilateral. As you can see, collaterals open up within 7 to 8 minutes and blood flow is completely established in 45 minutes. But the basic idea is you want to have a clot formation over there, and clot formation will occur only if you have a proper compression effect from inside. Externally you are compressing, internally also compression effect should be there with the packing. Let's come to obstetric hysterectomy. Next, please. You can have obstetric hysterectomy, antepartum, peripartum, and postpartum. What is peripartum? Performed at the time or within 24 hours of delivery. While postpartum is after 24 hours up to discharge in a single hospitalization. That's called as postpartum hysterectomy. That means after 24 hours up to discharge in a single hospitalization. Clear? Next. It can be in emergency. For example, rupture uterus, uterine pathology like fibroids, vascular lesion, anatomical anomalies causing hemorrhage, atonic PPH, DIC, sepsis, choriocarcinoma, coeliar uterus, etc., etc. Next. It can be elective, particularly in cases of morbidly adherent placenta, where you plan it in advance that I have to do elective hysterectomy, CA cervix, CA ovary, and as a method of sterilization, which was being done during my time. When I was a resident, this was very popular. As a method of sterilization, do hysterectomy. Next, please. How does it differ from a gynec hysterectomy? Here you have to take care of the mother as well as the fetus. Choice of anesthesia will again vary because pregnancy is there. Now, if patient is transferred, you have to keep in mind about anemia, shock and hypotension, infection, dehydration, because majority of the time they are dehydrated, majority of the time they are in shock, acid-base imbalance, electrolyte imbalance, DIC, distorted anatomy, malpresentation, anuria, renal failure, and unknown medical diseases because patient has been transferred without proper history being mentioned. Next, please. How does it differ from gynec hysterectomy? It requires team effort. That means seniors, expert gynecologists, neonatologists, team of anesthetists, intensivists, urologists, and many helping hands. Presence of a mixture is required because you have to do internal ligation. Blood bank, blood and component availability, invasive monitoring, increased vascularity, size of uterine corpus, and difficulty in identifying the extent of cervix. However, the advantage is tissue planes can be identified easily due to edema. So separation of the tissues become much easier. Next. Operative technique, it can be abdominal incision, can be vertical or transverse. Bladder flap completely separated by sharp dissection up to 2 to 3 inches below the uterine incision. Uterine incision can be classical or lower segment, which can be again transverse or vertical. Whenever I do hysterectomy in a case of placenta accreta, increta, percreta, I take an incision vertical only and go ahead with vertical incision over the uterus. Next, please. Operative technique. These are also little different from the regular hysterectomies. Avoid suturing the uterine incision. You can just apply 4 or 6 helices Apply pressure to prevent blood loss using ring forceps. Placenta should be removed as it reduces bleeding. And inspect ovaries decision to oophorectomy depending on the pathology and condition of the ovaries. Next, please. What are the steps? 3 clamps at the cornu, 1 at the cornual end and 2 over the uterovarian ligament, mesosalpinx and round ligament to have an adequate length. Why it's important? To prevent slippage as pedicles are large and edematous, possibility of cut through due to increased friability, and what is more important is you have to clamp, cut and drop. You don't bother to transfix the clamps at that time. Snug fit of the cornual stump to prevent back bleeding, because back bleeding in a pregnant uterus is too much and patient can have severe blood loss at the time of hysterectomy itself. Next, please. Double ligature at each stump. First clamp and cut all the structures up to the uterine vessels and then tie to prevent blood loss. So you keep clamping, cutting and dropping it till uterine vessels and then you suture all of them. Skeletonization of uterine vessels. Avoid excessive dissection to prevent injury to the uterine vein. You have to keep one thing, visualization or palpation of ureter before clamping the uterine vessel, because you forget one thing, that this is a pregnant uterus, and pregnant uterus, the uterine and the ureter are very nearer to each other at that level of internal os. So you have to be very particular about ureter being clamped in your uterine vessels, and always use Heaney's clamp. Next, please. You can do subtotal hysterectomy, which is quicker and safer, less blood loss, less injury to pelvic viscera. Can be safely advocated for indications like atonic PPH, rupture involving upper uterine segment and fibroid uterus. Ideal thing is to do total hysterectomy. Next, please. How do you identify the vagina? Identification of the vaginal angle by compressing the angle of vagina with thumb and forefinger. Identifying the cervix by palpating the edge through the uterine incision. Whatever incision you have made over the uterus, you put your finger inside that and palpate the edge. Extending the uterine incision through the cervix, and that is how you will know that this is vagina. Or lastly, entering the vagina posteriorly, which is much easier as compared to anterior, because you are scared of the bladder being there. So once you have identified, it becomes easier to do a total hysterectomy. Next, please. What is more important? Vagina may be sutured prior to removal of the clamps. Drain may be left coming out through the vagina. Avoiding suturing of the utero-ovarian stump to the vaginal angle. Don't suture utero-ovarian stump to the vaginal angle, please. Next. How do you prevent excessive bleeding at the obstetric hysterectomy? You can have uterine artery embolization, or you can have a balloon put in both the uterine arteries, which can be inflated at the time of hysterectomies. Intine-like ligation, temporary occlusion of ovarian and uterine vessels with vascular clamp, pressure on aorta and delivering the uterus out and pulling it upwards so it kinks the blood vessels. Next, please. Interventional radiology can be with the help of uterine artery embolization or intine-like embolization or balloon. Next. It's highly feasible, safe and beneficial procedure, possibly precluding further laparotomy and hysterectomy. If successful, not only saves the patient's life, but also preserves the function of the uterus, tubes and ovaries. Next, please. But these facilities should be available. Here you can see it nicely. Next. Embolization done. Next. All clear. Next. Thank you. Thanks a lot. In fact, I had the video of all of them, but I thought the time constraint is there. That's the reason I didn't send the video. Otherwise, I had video of intine-like ligation. I had video of systemic devascularization. I had video of B-Lynch. I had video of Heyman. I had video of all the procedures. maybe some other time.
Thank you, sir. I mean, so much of an exhaustive presentation, and believe me, a few of the sutures even I have not heard the names of. I don't know how you got your research right. I really have no idea. But as we all know, you're a great teacher, so you must have really dug deep into the topic. Sir, my only question to you is, when we are using the material for B-Lynch or Cho or Heyman, what does one prefer? Because there is this belief that we should use chromic catgut. Somebody talks about Vicryl, and now a new fad which has come is using Vicryl Rapid. So what is your impression on the use of any of these three?
See, I have been using only catgut, chromic catgut. The basic idea of using chromic catgut is uterus is the only organ in the body. I always call it as eighth wonder of the world. The reason behind it is it can extend up to xiphisternum and return back to original normal intrapelvic organ. This is the only organ in the body which can change its size and shape and depending on the requirement. Since it undergoes involution, we have done the tightening, that's fine. We have done B-Lynch or Heyman or whatever it is. But once the uterus starts involuting, the knot becomes loose. The Vicryl will be hanging and intestines can get stuck inside, resulting into obstruction. That's the reason we use catgut. I always use chromic catgut.
And another thing about this,
Rapid Vicryl has come because it gets absorbed faster. That's the basic
Yeah.
idea. And the reason behind catgut not being used is availability of the catgut has become
Catgut.
sparse.
sir, another thing which I found in my practice is I think personally B-Lynch becomes a little extra cumbersome, takes a little longer than taking multiple Heyman sutures. You know, when you have an upper segment bleeding, you need not encroach, go below the incision. You just require a straight needle, go anterior posterior, and you just make somebody tie. You
Correct.
push an assistant
I
tie.
totally agree with you. That's why B-Lynch is not that popular now. Heyman is becoming more and more popular because it's the easiest surgery which can be performed. And you
Yes.
can have number of sutures. You can have 4, 5, 6 depending on the requirement.
And the
And
same,
also,
yeah. Go ahead,
also,
Komal.
sir, yeah, no. Also, sir, like most of the time when there is a bleeding and you tend to close the uterus very fast. So after closing the uterus, taking B-Lynch becomes a difficult. You know, the decision of
You
B-Lynch
can't
needs
take
to be
B-Lynch.
taken.
B-Lynch
Yeah,
requires
it
open
needs to be
the,
taken before we close the
yeah.
uterus. So I think that we are not taking B-Lynch that often, but Heyman's definitely. And availability is the issue. It's not available, sir, all OTs. Vicryl is the only available. So, Joe, whatever, even the straight needle is not available, sir.
I have Vicryl, catgut, everything with straight needle, with 50 mm needle, which is very useful. Let me tell you, you'll have to tell the person to get you 50 mm needle.
It is
And with
very
50
difficult.
mm needle, it's very easy to have.
Sometimes the uterus are very huge. It becomes very difficult.
Yeah, I do agree. But 50 mm needle serves the purpose. I do my uterine closure also with not standard 40 mm, but 45 mm needle.
Wow.
Sir, one more thing, what is your opinion about this Mahesh Gupta stitch? I think it sounds very, very logical and useful. You cover up a Heyman, you cover up a uterine artery, also ligation in the same stitch. What
I
is
do
your
agree.
thought
I do
on that?
agree, but it requires 2 stitches, two such packets, you know.
Okay.
For both the
That's the
sides.
only thing. Principle remains same. Whether you ligate it separately or you go through that, but it requires 2 of them.
Anyway, thank you, sir. Any other questions from anybody else?
So,
May I just add on something?
Please.
Please.
Komal has been talking about the needle. Komal, I know we don't travel by train so frequently, but if you're traveling by train, you know, the people who comes to sell the local chota cheese, they have those big long needles, and we've actually purchased 2 of those needles, and they've got big eyes. So you can thread whatever Vicryl, whatever catgut into it. It's a straight needle and you can use it for suturing, and it doesn't cost much. It can be autoclaved and kept in your OT.
Wow,
So, you know, they use it for gunny bags. पर
Yeah.
उसको लेके ना ऑटोक्लेव करके रखना पड़ता है.
Recently, I had a big prick. It was called an emergency, and there was a huge uterus. My needle couldn't go. And I pricked my own finger because of that.
Correct, correct. That is why those big straight Purana wala needles, they would.
So I think I'll have to now hunt for those needles.
Tell somebody to buy it for you.
Simple. I can make it simpler for you, Komal. Rather than going by train and getting jostled, go to one Gadi wala, the one who makes Gadis, you know.
You can do that, yeah.
You also get it there. So not.
Yeah, I'll donate all the places where I go. I said, please give this needle. Yes.
Anyway, thank you, sir. Pleasure always, as always. Thank you so very much.
Thanks for giving me the opportunity, please.
Yes, sir. It was revisiting your teaching, then actually imagining things, how it went all through, like how we learned. So happy and so fortunate to chair your talk. Thank you so much, sir.
Thank you.
And with such eminent teachers, to add on, Dr. Pandit Madam also our teacher from Sion Hospital. So it is really a blessed evening for me. Thank you, Sneha, for making it happen.
Thank you. Thank you.
Thank you. Thank you so much, Komal.
Thank you.
Thank you, Dr. Motwani, sir, and thank you, Komal ma'am, for the great inputs. And thank you, Sarogi, sir, for great talk. Now we will move on to session number 2. Speaker is Dr. Suchitra Pandit ma'am, and we have got the chairpersons for this session, Dr. Mohan Gadam, sir, and Dr. Karthikeya Bhagat, sir. Dr. Mohan Gadam, sir, he is obstetrician gynecologist in Mumbai and has experience of more than 42 years. He is practicing at Nanavati Super Specialty Hospital. He has special interest in high-risk pregnancy, diseases in pregnancy, laparoscopic surgeries. He is from KM, Mumbai, and Dandijo from the CPS, Mumbai. Welcome you, sir. Dr. Karthikeya Bhagat, sir. He is the consultant OBGYN at Grace Maternity Home, and he has worked at Municipal Maternity Home also. And he is the founder member and past president of AFG and member of managing committee of BPNI Maharashtra. He is also international board certified lactation consultant. Welcome you both, and over to you, sir. And please take over. Thank you.
Thank you, Madan. Thank you, Dr. Sneha, for inviting us. It is a pleasure to introduce Suchitra. I mean, थोडक्यात म्हणायचं तर मूर्ती लहान पण कीर्ती महान. And that is Suchitra for us. Now, everybody knows that she's a past president of the Mumbai Society, Foxy, ISOPAP. She's a president, been a president of the Gestosis Society. And she's actually an associate member of the FIGO Ethics Committee and the Foxy representative to SAFOG. Now, all this can't happen in a jiffy. So she's worked from the ranks and she's come up all the way here. And all this is possible because she's a learner and a teacher. And apart from that, she wants to propagate whatever she's learned and pass it on to people. This warm personality is what I give you. And as you found out a couple of minutes ago, she's grounded in reality. She travels by trains and she picks up needles from the haystack. Suchitra, the window is yours.
Can I share screen?
Yes, madam.
Yeah. Yeah. Are you able to see it?
Yes.
Yeah, I'm just making it full screen. Okay. Is that okay, full screen?
No, it's not full screen.
Not yet, ma.
Okay, just a second. Again, we'll have to try again. I think it should be full screen now.
Yes.
Yes, ma'am. Yes.
Yeah, okay.
Perfect.
So first of all, thank you very much for the kind words. And whenever I think of Karthikeya, I always think of the north face of Kailash. Because when I did the Kailash Manas trek, there is one particular part where you get up early in the morning. There's the most difficult day of the trek. You see the northern face of Kailash. It looks very much like Shiva's, the outline. On one side is Karthikeya and on one side is Ganesha. And believe me, Karthik, when I did the trek, I remembered you that particular time. So every time I think of Karthikeya, I think of that Kailash. So it's very good memories which come back to me. Well, and thank you very much, Sneha, for the opportunity. Thanks to AMOGS and thanks to all the team members for giving us this opportunity to talk about prediction and prevention of preeclampsia. In the last few years, we've been working on gestosis, and we know that the number 2 killer in our country is hypertensive disorders of pregnancy, and particularly in states like Tamil Nadu is the number 1 killer. So in other parts of the states, the PH still comes as number 1, but there the HDP has taken over. So if we have some better method of predicting, we will then know how to prevent it. But we understand that HDP is a complex and a perplexing problem, and that constitutes around 10% of the pregnant women globally. Preeclampsia per se affects 3 to 5% of pregnancy, and we talk of HDP as a big umbrella term. It includes preeclampsia, eclampsia, gestational hypertension, and chronic hypertension. And as I've mentioned, that in various countries, there is a difference in inequity, and probably that's where the rates of the causes of mortality and morbidity change. So when you look at a quick definition of preeclampsia, it's a disorder of the widespread vascular endothelial malfunction and vasospasm that occurs after 20 weeks of gestation and can present as late as 4 to 6 weeks postpartum. And beyond the diagnosis, there is a very high unmet medical need for more reliable, predictable markers, because then only we can improve the maternal and perinatal outcome and reduce the unnecessary hospital admissions. There's lots of research going on around the world, but because there are so many different phenotypes of preeclampsia, we probably have to wait and watch and see what predictor fits the bill in that particular country. So what is the importance of screening? We know screening is the systematic testing of asymptomatic individuals in a general population, and it allows early detection and planning of appropriate monitoring strategies. You can actually intervene and put in the appropriate interventions provided they are easily replicable. And of course, there's always going to be a false positive, false negative rate with any prediction test. But what are the challenges that we face in low resource settings? And I will be telling you something a little later. We talk of ourselves as low resource, but sometimes we surpass some of the neighboring countries around us. So let us look at some of the older tests which were based on placental perfusion and vascular resistance, like rollover, like intravenous infusions of angiotensin, like renin, like the 24-hour ambulatory BP monitoring. Then you had tests for the feto-placental unit dysfunction, like all the various biochemical markers, including PAPS, PAPA, and inhibin. You had the markers for renal dysfunction, like microalbuminuria, urinary calcium excretions, and you also had the endothelial and oxidant stress dysfunctions, so many of them. But then they did not have that function of a single reliable test. So therefore, in our country, we believe that prediction on the basis of clinical risk factors is the best. And I'll just give you a quick idea about what the tests are. So if you're looking at any ideal test, it is based on maternal history, maternal blood pressure. Uterine artery Doppler is the newer entrant. Biochemical markers and combinations of all these are the most recent. So let's have a quick look. If you have a maternal history of PIH, then it's an 8-fold increase in this index pregnancy. Similarly, if there's an obesity more than 35 kgs per meter square BMI, then there's a 4-fold increase in PIH. Along with that, the history, the age, whether there's existence of your single pregnancy or multiple pregnancy, whether you're a primipara, whether you're a multi, what origin you belong to. And Southeast Asian and African probably have the same predilection rates and history of renal disease. So on the basis of this, after doing a lot of research through our Gestosis India organization, we came up with the Gestosis score, and I'm sure most of you know it. But now the fact which I would like to share with you is it has been validated by 2 centers, One study is already published in Jogi 2022, and there are 3 studies which are now given for publication, and nearly 8 centers are still doing that study and will be in the last finishing phase. So let's look at what it is. If you're looking at the mild scores, age less than 19 or 35 gets a score of 1, maternal anemia less than 10, BMI 26 to 30, a nulliparity or that is a primary gravida, short duration of paternity. Women, if they know about their weight as babies, if they don't know, that's fine. A history of PCO, which is on the rise, an inter-pregnancy interval of more than 5 years. If they have conceived with ART, that is IVF and ICSI included, if the mean arterial pressure is more than 85, and a chronic vascular disease, dyslipidemia, even a family history, and excessive weight gain, all these merit a score of 1. Now, in the next one, if there's a history of hypothyroidism, family history of preeclampsia, gestational diabetes, obesity 30 or more, and multiple pregnancy, it gets a score of 2. And if they have a HDP history in the previous pregnancy, if they're already having diabetes prior to conception, chronic hypertension, mental disorders, even depression, anxiety disorders, which require psychiatric treatment, are taken as mental disorders, thrombophilias, whether they're acquired or inherited, maternal chronic kidney disease, autoimmune diseases, and assisted reproductive techniques, where they're looking at surrogacy or egg donation. All these get a score of 3. So this is how it looks like, and this is available on the Android phone. Download it from the Play Store. It is known as the Gestosis HDP app. So at the first antenatal visit, take a careful history, give the points. If the points are 3 or more, she's at risk for preeclampsia, and start off on low dose aspirin, 75 to 150 milligrams. 75 is preferred, along with 1 to 1.5 grams of calcium. And remember, the gestosis score is not just for the first time. You can do it at every visit. And if you find the first time it was negative, it can be done again and again. You'll ask me the question in the later stages, after 20 weeks, if it's detected, what's the point? You're not going to add aspirin. But at least you know that this patient is at high risk and she needs to be monitored more vigilantly, and you might want to do other investigations like the PLGF and the S-split ratios. So I'm going to talk about that. So the gestosis scoring is simple. It gives an opportunity to reduce the risk, and it doesn't take more than 5 minutes to do the tick mark. Many people have got the printouts made and attached to their antenatal charts, but please use it. Anyone and everyone can use it. This is what it looks like. And defective placentation is the causative factor. But if you're giving low dose aspirin, it helps to maintain the adequate uteroplacental blood flow. And questions people ask is, why 75, why not 100, and vice versa? Well, currently we have adequate data for 75, and low dose aspirin has got a good maternal and fetal safety profile. Therefore, we recommend giving it. Best to give it at night time, and you can continue it right up to delivery. In fact, 2 days prior to induction, you can stop it. And if you have an emergency C-section, nothing to worry. So the next important thing is BP, measure it correctly. We normally do so, but in very thin patients and in very obese patients, we can do some gadbad. Therefore, we have to have adequate sizes of the cuff. And you do a Korotko 1 for systolic BP and Korotko 5 for diastolic BP. But if you find that the diastolic is persistently less than 40 millimeters, then use the muffling of the fourth sound to make a note. Remember, friends, this is basic, but this is very, very important. And all of us have the mercury. That is, the mercury is the gold standard sphygmomanometer. But sometimes patients can be trained to use the automated BP machine or the calibrated aneroid device. But Ask them to get that BP apparatus each time they come. And whenever you're taking the blood pressure, the patient should be comfortable. तंबाकू खा के आएगी तो गड़बड़ हो जाएगा, and she should have an empty bladder, be absolutely comfortable. And if you feel that the BP is high, repeat it after 10 to 20 minutes. And if you find that 2 readings are abnormal, take the third readings and then decide. What if the BP is 135 by 85? Be alert. Warn this patient to come back. If it is possible, she can do a BP checkup at home, or at least if she's in a smaller area, she can go back to her GP and check the BP again. Tell them, warn them about the dangers of high blood pressure and the need for follow-up more frequently. And at every visit, you're going to be checking all these important things. Ask for visual disturbances, epigastric discomfort, and increased edema. Another system which has people have used is a full Pyers model, where they are looking at all the small aspects that we've already discussed. They say that if you are able to recognize women at the highest risk of complication, you could probably transfer these patients much more earlier. So again, the same factors, they look at all the various histories. Only differences in the mini Pyers, they are looking even at the pulse oximetry, and they're also asking for visual changes. But in the full Pyers, they're looking at platelet count, creatinine, and SGPT, SGOT. And if these are found to be high, they're transferring the patient. Now coming to the marker 2, we've already talked about BP. The mean arterial blood pressure is important. If you do that correctly, you can detect early onset preeclampsia and late onset preeclampsia. But when you're looking at uterine artery Dopplers at 11 to 13 plus 6 weeks, the preeclampsia rates improve much more. Now let's talk a little more about what the combinations would be, and these would be dependent on the protein biochemistry of Pape. So the combinations will be the maternal characteristics, the Dopplers, and the biochemistry. And these are able to pick up 80 to 90% of early onset and 60% of late onset. But you have to look at the cost benefit ratio. So uterine artery, we all know that it's not difficult to do it. And all the patients who've had abnormal uterine artery Doppler changes, you have to follow them up, and it would be a great idea to check their histopathologies. And recently I learned in one of the wonderful international webinars that the placental pathology, even for that, you need a proper trained perinatal pathologist who will be able to tell you what exactly went wrong in that placenta. And of course, sonologically, our sonologists look at the color mapping. Diastolic notch is no longer considered, but they calculate the mean pulsatility index. If it is more than 95th centile, it is labeled as high risk. So at the first trimester, when you're doing the nuchal scan plus dual marker, if Pape mom is less than 0.5, we always know it's a placental dysfunction. So you may have a fetal growth restriction. But when you're combining umbilical artery Doppler plus you're combining Pape, you probably get better detection rates. And if the PI is more than 2 standard deviations, they take it as a screen positive and recommend starting low dose aspirin. So Pape, I've already mentioned what it is, but if you have a low level, it is associated with a higher incidence of preeclampsia and FGR. And if you're looking at a placental growth factor, this is a vascular endothelial growth factor, where at 11 to 13 weeks, it should increase. But if there is a fall, it means that there is impaired placentation and there is aneuploidies. And in the second and third trimester, these patients would be probably developing preeclampsia or FGR. And as far as Pape is concerned, we already know that first trimester Pape and second trimester S-split PLGF ratio can actually predict late onset preeclampsia, and the detection rates are as good as 87% with a false positive ratio of 5%. So let's now have a look at this particular combination. When you combine uterine artery PI with the maternal factors, you are getting a much more better prediction, a higher sensitivity than just medical history alone. And This will tell you now the mean, the maternal factors, the MAP, the uterine artery PI plus a PLGF. The detection rate before 37 weeks is almost 82%, and for preeclampsia after 37 is 42%. So there's no doubt about the fact that if you can afford to have the entire combination, your prediction rates are much more better. Now, the FMF Fetal Medicine Foundation has made use of this. They combine the a priori risk from the maternal factors, they combine it with the biophysical and the biochemical measurements, and they have done this on the basis of a prospective multicentric study. They screened at 11 to 13 weeks, and they found that when you're combining everything, the detection rate for a preeclampsia less than 37 weeks was 77%. But for more than 47 weeks, more than 37 weeks, it falls down to 43%. So this probably is something which they have found with all the other studies in common. And Aspray clearly demonstrated that when you administer aspirin compared with placebo, it resulted in a 62% reduction in the incidence of preterm preeclampsia, but had no significant effect on the incidence of the term preeclampsia. So they have recommended 150 milligrams. So this is the FMF chart when they're looking at all the different parameters. They're taking the bloods and they're giving the risk ratio, they're calculating it, and they are recommending the giving of 150. Now, when we asked Leona Poon why was 150 given, she says probably that is the correct dose to reduce the complications of preeclampsia. But again, we are waiting for a study of 75 versus 150. So from the Justosis India Association, we're still continuing with 75. Now, just to look at all these guidelines, people love to look at NICE and ACOG, but NICE actually only is looking at high risk factors. So they're missing out a lot of the percentages of preeclampsia. ACOG again does the same, but ACOG does look at preeclampsia in a patient who has had a delivery less than 34 weeks. So they're again missing out. Aspray trial is giving it, but again, their improvement rate is 60%. So what we suggest that in India, where the access to first trimester, can we have a little silence, please? Can we mute, please?
वो दूध वाला पाउडर तो चालू रखना है सुबह से, पानी वाला दिया है ना, बस वो चालू रखना। अभी ओके है?
Can we mute, please?
Saiti, can we mute? Who is talking? Can please mute your.
So for India, where the access to the first trimester screening is not always feasible, Justosis is cheap, easy, promising, and now it has been validated. So all over at CEPHOC countries, we're recommending please use it. Now, the next little story about the S-FLIT. Now, S-FLIT is available in India also. It is a soluble FMS tyrosinase kinase anti-angiogenic protein, and the levels of S-FLIT increase to prior just before the preeclampsia. So, if you have a ratio of raised S-FLIT to decreased placental growth factor, if that ratio is elevated, the clinician should be alerted. And this is the basis of the prognosis trial, which investigates the use of S-FLIT versus PLGF, and they will predict the preeclampsia. And let's see how it helps it. If the ratio is 38 or lower, you know that come se come 1 week you're not worried. But if this ratio is more than 38, then you better decide about admitting this patient. So it's a valuable aid in diagnosis and discriminates between different types of HDPs. So if you adopt it in clinical practice, it has the potential to reduce the frequency of adverse pregnancy outcomes for the mother and the fetus. And is it available? Yes, very much it is available. And this is the basis of the PARROT trial. So PARROT trial 1 and 2 both are now done, but we have the results of the PARROT 1. Here they do a single PLGF test for women who are coming to the emergency room, and those who had a positive result, it halved the time to diagnose preeclampsia and significantly lowered the chance of serious complications for women. So this is the basis of the screening test, the S-split, the PLGF ratio, and this is how, of course, this is one of the tests which I'm putting, the AVCO screening methods. This is what the results look like, and this is what tells us if it is less than 138, the patient will not get preeclampsia for at least 1 to 4 weeks. If she is more than 38 and less than 110, chances are that within 4 weeks she will develop preeclampsia. But if the value of the S-split on PLGF is more than 110, please admit these patients because they are likely to start throwing a convulsion. Now let's look at the newer tests. One of the very promising tests which WHO has promoted is the Congo Red test. Here women with preeclampsia have misfolded proteins in their urine which bind to the Congo Red dye, and this is an azo dye. This colors the urine red. So if you find that this test is coming positive, this patient is likely to develop preeclampsia. And this is a prospective diagnostic case control study in about 409 women, 200 done at Bangladesh and 200 at Mexico. And the primary outcome was development of urinary congophilia. And secondary outcome was to confirm how that test would be. And it was found that wherever it was positive, those patients did develop a preeclampsia. And therefore, this seems like a very promising tool for rapid identification. We're looking forward to WHO for having actually, putting this test out in practice for use of public. Another new test, just a few more slides and we'll be done, Sneha. High levels of cell-free fetal hemoglobin are found in placentas of patients diagnosed with preeclampsia. And HbF has a property which has got inflammatory and oxidative tissue damage action. So now what can be done for this? There is a protein called A1M. A1M is identified as a reductase and a binder of heme group and organic radicals. And in a simple form, if IV supplementation of recombinant A1M is given, it has protective properties and it can therefore prevent the tissue damage from the oxidative stress, and the incidence of women having very high levels of HbF in preeclampsia are high. So they have found in few 28 patients they had done the study where this IV supplementation of recombinant A1M actually reduced the HbF and prolonged the pregnancy by some more weeks. So again, there was an open pilot study where they have removed some of these problems and they have removed the circulating S-split, which is responsible for the damage. They've done dextran sulfate apheresis, and they found that the mean S-split levels were reduced by 18%. So this is again hoping that it will come out very soon in practice. And this trial again tells that we are waiting for this therapeutic apheresis to become a reality. And the last slide, emerging role of mesenchymal cells. We are all now today familiar with cord blood banking. So the human umbilical cord blood is rich in mesenchymal cells. They contain similar features to the mesenchymal cells found in bone marrow. So the regenerative effects of placenta or umbilical cord derived MSCs could potentially treat the endotoxin-induced hypertension that occurs in preeclamptic patients and probably try to prolong the pregnancy a little more. So therefore, what is there in our armamentarium? Apart from the predictions, healthcare workers and patients have to understand seriousness of HDP, and majority of the times it has been found that women who are getting treated for HDP are not actually knowledgeable. They're not taught about it. They're unfamiliar. So probably if we give a better communication to them, give them more material to read out, focused information, and educating the caregiver is strongly needed. So though we have ultrasound, Dopplers, biochemical markers, public hospitals may not have trained manpower, machines, and biochemical markers. Government of India currently says 2 scans is what we can afford. We do the first trimester scan and you do the 20-week scan. Uske baad hamare paas scans nahi hai. So then why not adopt the Justosis score? easy to use and a practical method for prediction. Of course, if Congo rate comes, it will be great. But remember, gestosis score के लिए कुछ भी आपको खर्चा नहीं करना पड़ता है. Yes, it's not available on the Apple right now, and Dr. Gorak is trying his best to get that app ready. But join the gestosis movement, which means preconceptual counseling, definitely early antenatal registration, use the gestosis score, use low dose aspirin and calcium, monitor mothers more vigilantly, and of course the babies use Maxel for preventing eclampsia, and even in severe preeclampsia, use it so that you can give benefit to preterm preeclampsias for neuroprotection of the baby's brain. Timely transfer to a tertiary care center where complications are anticipated, and monitor BP in the postpartum period. Friends, this is something we are constantly forgetting. Don't discharge the patient in a hurry. In the public hospital, Janani Suraksha Yojana, they want to quickly send the patient home. But in these cases, wait, watch the BP. It takes 2 to 3 days for the BP to settle down. If it hasn't settled, send her on an antihypertensive. Call her back after 2 weeks, monitor the BP. You can change over to easier medications like amlodipine post-delivery. But friends, sometimes the preeclamptic patient can suddenly start having a press syndrome in the delivery period. I've had a patient recently do that. No hypertension in pregnancy, and she ended up having press. So we have to be very, very careful about these atypical patients. Lifestyle changes, losing weight, discussing contraception, and advise patients to come for preconception counseling in case of a desired pregnancy. Thank you very much. Thanks again, Sneha, and I congratulate you for your efforts in bringing forth educative webinars, and sincerely wishing you all the best. And friends, we all have to make sure that Sneha is elected successfully this time. Thank you very much.
Thank you.
Thank you, Suchitra, for that talk. It was actually elevating to find that so much of work is being done in the realms of preeclampsia, eclampsia, and the hypertensive disorders. And at this juncture, let me put it on record that now gestosis score is India's contribution to the world of hypertensive disorders in pregnancy. Now, it is so nice to find that so many tests are being devised. Now, we are trying to, get to, or we are trying to pick up the disease at the earliest so that we can prevent problems. But at this juncture, in spite of so many tests, now you need a test which is available at the point of care. You need a test which is easy to use, cost effective. So how would you put this in a nutshell and say that, okay, in a low risk pregnancy, this is how I will.
So what I normally do is at the first visit itself, I calculate the gestosis score as you're taking the history. And once you get a habit, now it's very easy to calculate it. If it is less than 3, and I feel this patient is absolutely fine, when she comes back to me for the first trimester scan, I calculate the gestosis score at every visit. Sometimes, patients get a score of less than 3, but they have 1 or 2 high risk factors, like say a family history of dyslipidemia, or they are on the heavier side, or they've got 1 history of PCOS. So those I put a tick mark and I recalculate the gestosis score again. So it's a dynamic score, and right up to 20 weeks, you can start off with low dose aspirin. And it does not cause any harm. Only things you have to tell the patient, if she has acidity, if she has bleeding, then she should report back to you. Otherwise, most of my patients take it at night. There isn't much of a problem. And even after 20 weeks, when you're calculating the gestosis score, if it comes 5, you tick mark and say this woman is likely to have a preeclampsia. So monitor her more frequently. See, most of us in bigger cities will be doing the first trimester scan and the anomaly scan. But in a smaller place, sometimes the nuchal scan is not done. They're straight away doing only the anomaly scan, that too sometimes at 20 weeks, sometimes at 22 weeks. But try to get them to have that anomaly scan. And if they've already taken the ecosprin, there at least one small preventive measure we've taken. And when we've given that preventive measure, we also try to educate them and tell them, देखो भाई blood pressure अगर बढ़ा तो आपको झटके आ सकते हैं, बच्चे को धोखा हो सकता है, आपकी जान जा सकती है. तो बेटर है आप नियमित रूप से बीपी का तपास करते रहना. एंड इफ इट्स इज एन ओबीस पेशेंट ना कार्तिक, बहुत बार गलती हो जाती है बीपी लेने में. सो दैट इज समथिंग our BP apparatus have to be better calibrated to take those obese patients and very thin patients का मैंने अक्सर देखा है, there is a wrong finding. So I think these are the things. And MAP is again not difficult to calculate. So MAP also is a marker for us. So even if we don't have the S-split and the PLGF ratio, we are still okay. We can still carry on with the simple gestosis score. Only thing is BP monitoring of frequently below. Then, after 20 weeks, call her back in 2 weeks time. If she has facility to take BP at a GP's place, tell her to do that. And nowadays, these are not very expensive to buy also. Middle class family can afford to buy the BP apparatus. Sirf ek baat hai ki call them, tell them to get the apparatus to you so that you can calibrate that every now and then. And of course, jahan possibility hai nuclear scan ki, you many a times in high risk women, we combine not just the dual marker, we are combining the additional tests. But additional tests, like the PLGF ratios or the S-split, cost obviously goes up. But what
they are not easily available.
And the company people are saying, if more people use it, we'll have more authentic data.
It works both ways. It works both ways.
It works both ways.
So I think the point is that we need to be extra cautious. It's a huge problem because India is a country of contrast. Absolutely. There are people there's a places where there are no doctors and there are hospitals with everything available.
Absolutely.
So we need to devise a system, but the key issue is that you need to be aware.
Yes.
And you need to educate people. And unless they are educated, things will not work out. I think out of all the tests that you described, I think Congo Red seems to be one of the most promising tests.
Yes.
If it's validated.
Because
instead of doing urine albumin and all that,
yes,
probably
absolutely.
This will be a key test.
In fact, we are looking up to the WHO to get it forth very quickly. But
Yes.
we're still waiting for some more trials before they
Fair
can
enough.
say, okay, this is a good
Fair
test.
enough.
Yeah.
But thank you very much for that interesting talk. Mohan, I think you should come in and say something.
Yeah. Suchitra, I'm so sorry that I'm little late because my net was not working properly.
No problem.
But I've heard your talk, excellent talk, no question about it. But Suchitra, I just want to ask one question, that the concepts about preeclamptic toxemia are changing day by day. New scores are coming up, new trials are coming up, things change. The definition of blood pressure, high blood pressure in pregnancy also keeps changing. So, but we know Indian gynecologists and obstetricians know preeclampsia so well because we deal with it day in and day out. But we don't know about preeclampsia so much. So the way that your talk has gone, I don't know. I don't really understand whether most of the gynecologists are really applying these parameters to find out whether this particular patient is at high risk or she is going to develop or she is not going to develop. So what is your take on this? That is one thing. And after having done so much for preeclampsia, right from Leon Chesley's time till today, and you're the godfather, Dr. Girija Wagh, yourself, and people have done so much work on hypertensive disorders of pregnancy. So I just want to know whether there has been any beneficial effect over a period of last 40, 50 years, whether the incidence of toxemia, one of the triads which is responsible for maternal mortality, has substantially gone down.
Yes, very, very important question. In Dr. Gupte's year as Foxy president, he had started the eclampsia registry, which is still on. So the incidence of HTP, now it is being better diagnosed. So if you're looking at the incidence of HTP, no, that has not gone down. But the incidence of eclampsia definitely has gone down. In our times, we used to have a incidence between 10 to 12%. So now that eclampsia, the severe pre-eclampsias have gone down. Eclampsias still are occurring, but the incidence is much more lesser. And now more and more people are using Maxel. I'll tell you, before 2012, the government had reported that nearly only 20 to 30% were using it. Now the recent reports say that nearly 70 to 75% of the government setups are using Maxel. In fact, now we want to tell the private groups also, please use Maxel more confidently. Blisson has come out with a wonderful, they have a 4-gram IV pack. You just put that IV line and connect it to this. You don't even have to calculate the number of ampules, and it is all done and ready. So, things have definitely changed. Now people are more aware. Now patients themselves come and say, oh, my BP, that sister took, but doctor, can you just take it again? I think that BP may be a little higher. This is with the educated patients. But even in the smaller setups, even in the medical colleges, people are now little more conscious. See, that's how the maternal mortality has definitely come down. The maternal mortality has come down because of the two major things, and the third is, of course, infection control. So
Right,
now
Suchitra,
what?
that's
Yeah.
No, that's really great. That eclampsia incidence has definitely gone down, no question about it.
Yes.
But another question to you is that 150 milligrams of ecosprin this thing which
75.
has been
75.
advocated.
Yeah.
What percentage of toxemia patients or severe toxemia patients, early onset toxemia, has really come down?
Oh.
Has it really come down, or what percentage that it has come down?
I'll tell you, you're able to predict, so you're able to monitor those patients much more better. You're able to pick them up in an earlier stage and give them the treatment. Why it occurs, we still don't know. We are treating the symptoms, we're not actually knowing what the cause is, unless we all start doing histopathologies and finding out the cause. But we are at least able to pick these up much more earlier, screen them and deliver them. If it's severe preeclampsia not responding to treatment, we deliver them. If it is a severe preeclampsia where it is preterm, we try to give them Maxel so that the neonatal outcomes are better. But if they are mild to moderate, the word now mild to moderate is not there. It is non-severe and severe. If it is non-severe, we can take them up to term. But at least now, we are telling people start the medical management, that is the antihypertensives at 140/90 on 2 occasions, 2 hours apart or 60 minutes apart, whatever you're taking. But don't wait for 140/100. It is 140/90, which is now the cutoff. So the CHIPS trial has clearly shown that the earlier treatments are going to give you more benefit in terms of perinatal outcome and maternal outcome.
Madam, can I ask you one question?
Yeah.
Yeah. In your experience,
Yeah.
while monitoring a patient of preeclampsia,
Yeah.
in the antenatal period,
Yeah.
how much significance do you give to uric acid, LDH, and platelet count?
Yeah. Platelet counts and LDH are very important. If you're having a high blood pressure, LDH levels and platelets, because if the platelet is dropping, you know that this patient could be going in for a help. And LDH, if it is crossing 600, obviously it is a marker for help. But even 350 to 400, you be careful. I've had a patient who suddenly went into a full-fledged HELP syndrome at 350. But as far as uric acid is concerned, no, we're not looking at it as a marker. Older times we used to look at it, and we used to always include it in the armamentarium, but today there is nothing specific coming out of uric acid as a marker. So if you are doing it
not even for fetal health?
No. Surprisingly, all the studies are showing that uric acid ka koi role nahi hai. You're looking at Dopplers. I think now Dopplers have taken over, and now we've got such beautiful machines for monitoring. And even smaller babies, despite the severe preeclampsia, if they have their wonderful S/D ratios, if they have their MCA Dopplers, they are telling us a lot more. So now uric acid is not looked up to as a important test at all. Sometimes that part and parcel you continue doing it, but platelets definitely yes, LDH definitely yes.
Ma'am, this is Dr. Ujjwala Netam. I just wanted to ask very nice lecture. I just wanted to ask if we have a positive prediction at 12 weeks.
Yes.
I mean, a lot is spoken about ecosprin, but addition of calcium, double dose, and magnesium would definitely be helpful. There are a lot of studies that are going on. And
I've already mentioned that when the gestosis score is positive at the first visit, if it's positive, we start off with ecosprin and calcium, 1.5 grams of calcium. As far as magnesium, there is no study to support the levels of magnesium. Many of our calcium preparations already have magnesium in it, but we are not advocating additional magnesium. But if supposing you've not done the gestosis score and at the nuchal scan dual marker, you're finding that the results are positive, the FMF Aspray trial is saying 150 milligrams of Ecosprin, but we are still continuing with 75 because Leona Poon, I've asked her this question myself. So she said currently we do not have an RCT between 75 and 150. The moment we get that result, we'll be ready to switch over to 150. The reason I'm saying this is 150, there have been reports of sudden bleeding, abruption, and a stillbirth. So therefore, we are still sticking to 75 FMF tox. Calcium, 100% we include.
Is there any role of doing serum calcium then?
No, not really. Not at all. No serum calcium, no serum magnesium.
Okay, thank you, ma'am.
Wonderful, really wonderful. There is a question, Suchitra, I think it's best to hear from you that whether CPR has any role.
CPR?
Cerebroplacental ratio and nearing term in patients who has an early development of toxemia or pregnancy. So whether that has any role or you need to go ahead with other Doppler markers rather than CPR alone.
It is not just CPR.
Not for prediction, madam.
Yeah, for prediction. For monitoring, when you're monitoring your growth restriction,
yes.
CPR will not help you for your prediction at all. Monitoring, yes. Monitoring, you'll have to do Dopplers, plus you'll have to look at the CPR ratios also. But along with that, today, if you notice, the sonologists always recommend that in whatever pregnancy, please don't forget the 36-week scan where they're looking at the Dopplers and they're looking at the NCA levels. And then from there, they're calculating and they'll tell you, okay, you have this much time, or you can wait for 1 more week, or you can wait for 2 more weeks. And very nicely, those S by D ratios, and they've calculated. In fact, it's a printed chart they've given. Look at the fetal abdominal circumference, look at the weight of the baby, and look at the Dopplers. And according to that, you can decide how to look after these growth restricted fetuses. But CPR for prediction, no, there's no role at all.
I don't know whether they want to say uterine artery pulsatility index.
Now, are you talking about the uterine artery?
Yeah.
Yes, uterine artery, definitely. PI, uterine artery, PI, we are looking at that. We are looking at the uterine artery PI.
The discussion is very interesting, but I think we have a panel to follow.
Yes.
So at this rate, I think we will finish the panel.
Yes, yes.
Okay, wonderful talk.
Thank you so much.
Wonderful, thank you.
And Dr. Gadam, just one word. The word now, we don't use toxemia at all. We have switched over to HDP or we see preeclampsia.
So that's what I'm saying, Suchitra, that the nomenclature as well as every damn thing is changing about toxemia.
But see, maybe
over a period of time.
Maybe
the concept of blood pressure, the concept about bed rate, the concepts of anti-hypertensive therapy,
yes,
dose of Ecosprin, and every damn thing is changing every 3 or 4 years.
We're strictly following, International Society of Hypertension and Organization Justosis for our, inputs.
Yeah. Anyway, yes.
Monica, you can go ahead for the
Thank you, Suchitra ma'am, and thank you, Dr. Gadam sir and Karthik sir for chairing this session.
Madam Suchitra Pandit, thank you so much for your wonderful talk. And it's not only a talk; it's a huge discussion. I'm sure, right from the basic etiology to the advanced management. Thank you so much, madam, for your the contribution. Thank you so much. Yeah.
Can we now move ahead to the next academic session, that is the panel discussion? We have our moderators, Dr. Sneha Bhuyar madam and Dr. Rajendra Nagarkatti sir, who is also the convener of the series. Sneha Bhuyar madam is the chairperson of the Emergency Obstetric Committee. She has been the past chairperson of the Medical Disorders Committee. She has been the past chairperson of the FOXY Breast Committee also. She is also part of the managing committee of ICOG, as well as she is the president of IMA Yavatmal. We welcome you, ma'am.
You can skip the introduction, Monica.
Yes, ma'am.
Yeah.
Dr. Nagarkatti is also the clinical secretary of the Mumbai OBGYN Society. He has been the immediate past chairperson of the FOXY Midlife Management Committee, the immediate past chairperson of AMOGS Midlife Management Committee, and the founder secretary of ISPAB Chapter Mumbai. We welcome you, sir, as the convener of the series and the moderator for the panel. Our first panelist for today, Dr. Karthik Bhagat, sir. He is a consultant obstetrician and gynecologist at Grace Maternity Hospital. He is the honorary assistant professor at Akurli Road, Borivali Municipal Hospital, and the founder member and past president of AFG. We welcome you, sir.
Welcome, Dr. Karthikeyan.
Yeah. Our next panelist, Dr. Rakesh Pandya, sir. He's a consultant at Raj Nursing Home, Malad. He's also visiting consultant at Cloud9, an honorary gynecologist at Manav Kalyan Kendra and Navneet High Tech Hospital, Daisar. He's an advisor to the AFG, as well as an ex-trustee and past president of AFG. We welcome you, sir.
Thank you.
Our next panelist, Dr. Ujjwala Neta, madam. She has a fellowship in reproductive medicine, a fellowship in embryology. She also has a diploma in ultrasound, and she's a director of Sun Hospital and director at Dr. Ujjwala Fertility Center. She's an ex-honorary consultant at BDBA Hospital. We welcome you, ma'am. Dr. Dhaval Bervi is a consultant at Dr. Bervi's Nandini Hospital, Borivali. He is also the faculty and a postgraduate medical officer at BDBA Hospital, Kandivali. We welcome you, sir. Dr. Sargam is the director of Dr. Sargam Soni's Gynecological and Diagnostic Center.
She's not available.
Yes,
She's
ma'am.
left for the emergency. That is what
Yes,
she.
Dr. Navneet Desai, madam, is a consultant and director at Shobna Maternity since last 15 years. She's also the director at Joanna Hospital since the last 5 years. She's the treasurer of the Obstetrics and Gynecological Society and the honorary scientific secretary of AFG, the past president of IMA Meera Bhainder, and the past president of Bhainder Medical Association. We welcome you, ma'am. Dr. Pranita Bankar is our panelist. She's completed her MBBS from Terna Medical College and a postgraduate from the Medical College of Kerala. She has obtained fellowship in laparoscopic surgeries and she has worked at various hospitals in Mumbai. We welcome you, ma'am. Dr. Kritika Moge is a specialist at Cloud9 Hospital, Malad. She's also a consultant at Omkar Hospital. She has done her MBBS from Nair as well as MD from Topi, the same college. She has done her DJO from CPS. We welcome you, ma'am. Over to you, ma'am, and Rajendra sir for the panel discussion.
Thank you so much, Monica, for that introduction, and I welcome all the panelists. I hope you can see my screen. So I welcome all of you. Pleasure to have such senior people from, almost many of them are the past presidents of AFG. So I'm very happy to have all of you. And of course, I'm sure it's going to be a wonderful discussion. I'm sure the picture is self-explanatory, the near miss. And that's the very reason the terminology itself is borrowed from the airlines industry. It tells you the gravity of the situation and the urgency of intervention required. So this term near miss is actually defined as a critically ill, pregnant or recently delivered woman who would have died had it not been that luck or good care on her side. So all of us are here to discuss and analyze, because analysis will always help us to assess the quality of service and of course points to area of improvements. Because WHO says this terminology is also, it's synonymous with the severe acute maternal morbidity. And WHO says that almost 8.23% of this maternal mortality in India is preventable. So friends, this is not the maternal mortality rate is not just the statistics, numbers, rates and figures. These are women, and we obstetricians have seen them in the phases of their despair, distress and agony, and these continue to haunt our dreams. That is how it has been expressed by Professor Mohammad Fatala, the past PIGO president, and Ian Donald has also expressed in a similar way that over the clinical times, we tend to take for granted the success, but it's a failure which stands at like a keloid, always reminding you of your failure and hopefully the warning for others. I'm sure we all obstetricians, just feel that it is a normal labor and normal delivery, things will be all right. But in no matter of time, you find your patient in obstetric SDU or ICU. So all of us will agree to me that, the demography is changing, and so the risk of the incidence of this near miss is definitely increasing. Of course, the spectrum is also widening. So with this brief introduction, I would say even the senior most obstetrician, they will agree to me that every case is a new learning for all of us. So friends, never stop learning because life never stops teaching us. And with this brief introduction, I hand over to my dear friend, Dr. Rajendra, for further discussion. Over to you, Dr. Rajendra.
Thank you, Dr. Sneha. At the outset, I wish to thank you for organizing this webinar on this wonderful topic of emergency care in obstetrics, and to associate AFG with the AMOGS Emergency Obstetric Committee. Well, to begin the first case scenario, we have a second gravida with a previous cesarean section, one live birth. She comes to you with 7 days overdue with a UPT positive, and she wants a medical abortion, which is okay because she's only 7 days overdue. The doctor prescribed it and asked her to follow up after 7 days. Now, in that time, she had only spotting and giddiness off and on. And on the 6th day, she comes at 11 p.m. She has collapsed at home and she's brought to the hospital by relatives. Next slide. So let's begin the discussion with our opening batsman, none other than Dr. Karthik Bhagat. The patient is now brought to the hospital with a pulse rate of 132, blood pressure of 70 with a lot of pallor. So what would your immediate diagnosis be, and also the differential, what would you think of?
See, the first thing which comes to your mind is that you've missed an ectopic. So this is probably an ectopic pregnancy because you never confirmed that she was pregnant and it was an intrauterine pregnancy. So there are two issues.
Would you say that it is mandatory to do a sonography before you give the medical abortion pills?
See, it is not mandatory to do an ultrasound, but I would prefer to do an ultrasound every time I prescribe medication for abortion, because I don't want to land up with this situation. So if the woman comes early, she's just 7 weeks, 7 days, missed a period by 7 days, you may or may not see the pregnancy. But in this case, it is better to wait for a few days, confirm that intrauterine pregnancy, because you don't want to land up with this kind of a severe situation. This is a situation where the patients can actually die. So I don't think it's a good idea to just prescribe medication and follow them through. In terms of yes, madam.
Yeah, so I think the MTP law says that the drugs should be prescribed, not prescribed, but dispensed inside the OPD, and usually on day 1 and day 3. And before doing that, we need to do the basic investigations like CBC, urine, and screen like HIV, and also ultrasound report, which we are going to take a Xerox and keep one copy with us for medical legal records. Like they are now checking, like we are keeping a surgical MTP record. They are also checking the medical MTP records.
Yeah. Dr. Ujjwala, I would like to interrupt you. Did you say that according to the law, you have to do ultrasonography and keep a report?
Yeah, it is always better to do a...
It is not mandatory.
So it is, see, by law, it is absolutely not mandatory, but it is recommended for the safety of the patient and for yourself.
Yeah, ma'am, but there was a case which has happened in the periphery of Maharashtra where ultrasound was not done, and patient had 2 pregnancy in 2 horns. And then 1 pregnancy was removed, and then the patient continued with the pregnancy, and in that verdict, the doctor was considered responsible.
So here this is a different situation. What the medical legal, what the law expects is that whatever the it is about the acuity of your clinical judgment.
Madam,
it's not about
how do you rule out an ectopic or a bicornual pregnancy?
Ujjwala, at this juncture on this platform, we are talking of medicine. So let us stick to the clear guidelines as far as the medical care is concerned. Now, when you pointed out there was a case against a doctor. Now, it all depends on what went, the records you kept, and how your case was represented by your lawyer. So I think let's not get into medical legal issues of all this. We'll stick to the facts. and say that it is always better to do an ultrasound and confirm an intrauterine pregnancy before you dispense medicines. Now, the law doesn't want you to do it. The MTP Act does not say it. So it's not that you can't give medicines. You can give medicine because the chance of an ectopic pregnancy is very low. So maybe out of 800,000, you'll end up with one case of an ectopic, which is not very common. So I think let's get on. And before you do an abortion, you must have a blood group, the basic hemoglobin values. And I think it is good to do the infection screen because you don't know which patient will come back with an incomplete abortion at what stage of time. So I think this is something simple. The simplest and the basic investigations are just these. You can always add on whichever investigation you want, but this is the basic investigation I would do.
Yes. So you're perfectly all right. You have to do the basic investigation, what you have just said, the CBC blood group and tridot or HIV. And of course, the ultrasonography for the safety of the patient, you have, the clear picture. So what is your differential diagnosis, Dr. Karthik here? And how would you manage this patient? Yeah.
See, the differential diagnosis would be this is basically a hemoperitoneum. Or basically she's collapsed because
it could be an incomplete abortion with excessive bleeding also.
Yeah.
No.
You cannot say that the patient is bleeding. So it's either a ruptured ectopic or a corpus luteum hematoma, which is bleeding with a pregnancy, or it's a pregnancy which is in the isthmocele. So it's a scar pregnancy which has
perfect.
So you really don't know what you are doing.
Basically a ruptured ectopic
As far as investigations are concerned, when the patient comes to you, you need to confirm, you've already done the basic parameters. So you know that she is in shock. So you will resuscitate her. Now you need to find out whether there's hemoperitoneum or not. So the easiest investigation is ultrasound, which will tell you that there's fluid in the abdomen. If you don't have facilities for ultrasound, if you are in a rural setup, then you can do a synthesis. So you can just put a needle in the abdomen and find out, or through the abdomen or through the vagina. So you confirm that it's a hemoperitoneum, and the only option you have is surgery, and you need to keep blood ready.
Yeah.
These are very risky cases, especially when you're going to do a laparotomy or laparoscopy, because the moment you open the abdomen, she'll sink and she'll have severe hypotension. So it's good to keep blood ready. And this is one place where autotransfusion may be done.
Okay, so these are the investigations clearly gives you the diagnosis of, severe anemia with the ruptured ectopic pregnancy. How would you proceed with the management per se, whether you will go for laparotomy or laparoscopy, and whether you would go for a conservative surgery or salpingectomy?
In a patient who's in severe shock, I would straight away go with a laparotomy. I'm not very conversant with laparoscopy, and I think in such severe cases, laparoscopy may not work well because there's huge hemoperitoneum involved. I would prefer to do a salpingectomy rather than conservative surgery, because if there is an ectopic pregnancy, probably there's a problem with there's likely to be a problem with the tubes, and it can recur. So to put an end to a repeat performance, I would rather do a salpingectomy and leave it at that.
Correct. The messages you have given very clear-cut messages. In such situation, the emergency laparotomy, yes, there are, the proponents of laparoscopy who are talking about that if you have a very good gynae laparoscopic surgeon, definitely you can go ahead with the, quick laparoscopy, as well as, they can catch hold of the bleeding point. That is what the discussion is still going on. But yes, what are the, we have decided that, ultrasonography is only to rule out ectopic pregnancy. It's better that you do it for the safety of patient and for yourself. It is not mandatory by law. You have to do the basic investigation. You have to go for the counseling. So what are the learning points? What was missed? We have already discussed on this point. I think counseling is very, very important. If at all the patient lands up into severe pain or bleeding, she lands up into, she gets a fainting attacks, which are very, very suggestive of, the tubal stretching. So I think that is what we should always do. That is what the message from this case. So with this, we go ahead with the second case now. we have this 36-year-old lady who's having 7 years infertility. She conceives on, IUI. So her husband stays in Dubai and she stays in a village. But for this treatment, she has come to your place, and she is coming to you for regular NC checkup up to 24 weeks. And you tell her that everything is fine. So unfortunately, she is lost for the follow-up. At 34 weeks, she reports to a primary healthcare center where her, with severe edema and pain in upper abdomen. Her blood pressure is 176 by 116. Whatever little investigations they are done there, it is, they say that it is apparently normal. The medical officer at PHC gives only tablet Nicardia retard orally. So the patient was advised for admission. So she is, she's lost for follow-up, and after 2 days, she gets admitted at a higher center, that is sub-district hospital. Her BP is 168 by 110, and again the medical officers adds tablet labetalol. Because they have the anesthetists available, they immediately go for cesarean section. 1.8 kg live baby delivered. Still, in spite of all this management, the blood pressure remains between 140 to 180 up to 110 diastolic. So she is now on nifedipine, Maxelf and labetalol. So on the same day, around 10-12 hours later, she developed sudden severe breathlessness, restlessness, cough. Her pulse rate is 115, BP 220 by 118. Saturation drops to 70%. Chest is full of wheeze, no clear breath sound. So what is your differential diagnosis, Dr. Rakesh Pandya? And how will you manage this patient?
Looking at the history, this is a severe preeclampsia, which did not get enough treatment because of the poor follow-ups.
Yeah. I think we will go into the introspection or retrospection later. But this emergency, how would you manage, and what all things you will do? We will discuss that first. We'll like to hear from you.
In the background of the history, the first differential diagnosis can be two. One could be pulmonary embolism, and second could be pulmonary edema.
Correct.
If the BP was not so high, a patient who is suddenly sometime later developed cough, breathlessness, and restlessness with hypotension and low saturation. Hypotension, if it was there, then it could be cardiomyopathy. Yes. But we ruled that out, peripartum cardiomyopathy in this case, because of the high BP and the previous history. So I think we are left with two things, pulmonary embolism and pulmonary edema, in view of the severe preeclampsia. Correct.
So how would you manage this patient?
This patient is 10 hours post-op, so definitely she has an IV line. Immediately another IV line should be taken, and the patient's ABG should be collected, arterial blood gas. If you don't have the facility, you send it in ice, the syringe, to any other center which has this, and try to mobilize the patient to shift the patient to an ICU. The Foley's catheter.
Right now, here, do we want to do something with this patient? Because it's not allowed for you to transfer the patient in this condition where the saturation is 70%. So immediately we can also do few things for this patient.
The patient nasal oxygen will have to be started for the patient, and for this high blood pressure, first IV labetalol should be given.
Yes.
So IV labetalol in the dose of 4 cc of labetalol to be given slowly over about 5 minutes, 3 to 5 minutes, and monitor the blood pressure.
Yeah. Would you not like to give her propped up position? Are you suspecting pulmonary edema?
Propped up position,
yes. Like to give her Lasix?
If pulmonary edema is there, then that is an indication to give Lasix.
Yes.
To the patient.
Oh, yeah. Because we are already suspecting pulmonary edema.
Right.
So propped up position, high flow oxygen, and Lasix, these will be the immediate reactions we have to. Yes.
Yeah.
Labetalol, how much and how? How do you give, and how much time do you wait for the dose to act, or to the desired?
Labetalol, if you are giving, as I said, 4 cc slow IV, then in the next 10 to 20 minutes, you need to reassess the blood pressure. If it has not fallen adequately, then you can repeat in doses of 2 cc slow dilute IV to the patient. So labetalol has a high safety margin, but a short duration of action, and that is why you need to repeat the doses.
Perfect. Even it takes, the onset of action is also very fast, within 10 minutes.
Yes, fast onset of action and slow low duration of the action. So you can repeat the doses.
Yeah, that's the reason you need to maintain later on as infusion also.
Right, and pulmonary edema is one complication of pregnancy-induced hypertension or preeclampsia, where you will give Lasix to the patient.
Yes, yes. Only thing about labetalol, what is recommended and what we have been following is you initially give 20 milligram, wait for 10 minutes, and if that is not effective, it's not getting the desired lowering of blood pressure, you give 40 milligram. If that is also not working, you give 80. That means you have to double the dosage. And how much maximum you can give?
Maximum
120 milligram it is. We can give 120 milligram maximum you can give. And by the time, this all of you have done everything, but by the time it is simultaneously things are getting done, the patient goes, patient is getting shifted to ICU, but she went into cardiac arrest. So how will you manage this patient now for cardiac arrest?
I think one thing which we missed was to call for help. And the first help in a private setup or a small setup would be your anesthetist.
Yes, anesthetist.
Anesthetist is the first person.
Whosoever.
And in case of such a complication, it is the anesthetist who is going to help you out.
Yeah. Yeah.
A defibrillator may not be available at all hospitals, though it is most desirable.
Yeah.
And in case of a cardiac arrest, it is the intracardiac adrenaline and defibrillator, which are two things which the anesthetist may be more conversant than a gynecologist in administering.
Yes.
So an anesthetist is most important. In fact, call more anesthetists and more gynecologists to your help in such a scenario.
Yeah, yeah. That is why it is mentioned here that your anesthetist friend is already there, and while shifting to ICU, the patient developed cardiac arrest. Okay, so you're giving a chest compresses, A, B, C, D, everything you're doing. What else in addition to this chest wheeze is there? So the bronchospasm also, you may nebulize the patient.
Right.
Yeah.
That all should be done in the earlier stages once you have when you are resuscitating this particular patient.
Yes, this is what
before she goes into the arrest.
Yes, cardiac arrest, and
Cardiac
definitely you have
and
to
dopamine drip also can be started early.
Yes.
However, with a very high BP, again, I do not know medically
that is
how
why-
much
that is
dopamine
why
drip
this
is going to
comes-
act.
Yeah, that
But
is why.
Yeah, but once the BP starts dropping, then dopamine drip definitely will have a place.
Yes, yes. So, Dr. Ujjwala.
So,
yeah.
So I just wanted to state, because I had faced a patient of cardiac arrest 4 months back. So I just think that we think that the anesthetist might arrive on time, but whatever manpower is available in and around you, please take control of that and
that is what
allocate a particular work to only one person. Like we had only a staff of 5, and then I said, who has to call home? The cardiac ambulance has to call, one person will get the defibrillator from down, one person will start a CPCR, and then I intubated the patient immediately. So we should not wait, and by the time the cardiac ambulance came, so a BiPAP was available, he took over. So then at least the patient has reached the ICU. So I think, no one should face this emergency, but if faced, you should be ready to intubate. You should know, your staff should know where the
Dr. Ujjwala, I would say
laryngoscope
you are the best person to discuss the cardiopulmonary resuscitation. I would ask you how do you give the chest compression for the house?
Madam, before that,
please.
see, this is one situation which you are likely to face sometime or the other.
Yes,
So
definitely.
this becomes a team effort, and this requires regular drills. Which means you and your staff need to be ready to resuscitate. You must know the steps of resuscitation. And this is where programs like Manyata come into use.
Yes.
So if you are
so would be a better
accredited-
person to tell.
No, if you are accredited, if you are regularly doing these drills with your staff, then it becomes very easy for you to handle emergencies. So I think the key point here is to have regular drills and get accredited. And Manyata is not very difficult to get, and Manyata is one of the best accrediting programs that you can have. See, most of us practice in small nursing homes, and we are the only doctors available. So in your absence, your staff should be able to tackle some of the medical emergencies, and that is what Manyata teaches. So it empowers your staff to work on your behalf, and you're elevating the standard of care. So I think that is something which is to be taken home.
I fully agree with you, Dr. Karthik. And in fact, I would like to give the same message because ours is the only nursing home in the entire district which is NABH and Manyata accredited. And that is why I fully agree with you that your staff becomes, well trained, time to time assessment and evaluation and mock dress. This is definitely improve the quality of care. So, Dr. Ujjwala, I would just ask you to, introspect that what has gone wrong for this patient and where, at what stage it was preventable. If you think of this patient right from early pregnancy.
I think the blood pressure control should have been more precise, but then you are saying that she has arrived very late.
Dr. Ujjwala, I'm so sorry. I would like to interrupt you. We just heard Dr. Suchitra Madam's talk. The maternal characteristics, the age, the infertility, and I think I would like to throw some light on those aspects also.
Yes, definitely. But I think over here, the patient has reached the gynec at 34 weeks. So immediate section was done, but post-operatively...
No, my dear. She is under regular care of an obstetrician, 36-year-old lady, 7 years infertility, conceived on IUI. She's coming to the obstetrician regularly, investigated, and the obstetrician said that everything is fine now, and then she's lost to follow-up when she reports to the PHC. That is what the history is. That is where the role of the obstetrician comes, of the health education that you are high risk. And the maternal characteristics, when you can calculate the HDP gestosis score, she comes as high risk patient. And there comes the role of prevention of low dose aspirin and high dose calcium.
Low dose aspirin, high dose calcium.
Madam, even if you had seen her earlier, you would have picked her up saying that she is high risk for preeclampsia.
Yes.
But you would not have expected or anticipated a pulmonary embolism or a problem like this.
Yeah, that is
post-delivery.
That is okay, but some things which are preventable.
So the idea is to have proper antenatal care, pick up patients who are at risk, monitor them well, and that monitoring should go on even post-delivery. So at least 48 hours post-delivery is very, very important to us. And all patients are a risk till the time they go home and even afterwards, because all these can happen even later on.
Yes.
So if you picked up your patients earlier, then you're probably likely to institute measures which will reduce the incidence or prevent such incidences.
Yes, that is what the message is.
As ma'am said, this patient was in PHC. So the best that a person, gynec in PHC could have done is to screen this patient and send to RH, which is a rural hospital.
Again, there is a confusion. She was in regular antenatal care initially up to 24 weeks. Then she gets lost because the obstetrician says, the target scan, your basic blood investigations are normal. This is a common scenario. Okay, we are just hearing HDP gestosis score in the lecture and we are forgetting about it. And that is where the practical application, of the HDP gestosis score. This is what, this is the...
Madam, I would like to add one point that generally such preeclamptics who we may not be able to anticipate this complication like a sudden onset pulmonary edema. But typically in the postnatal ward, if there is a severe preeclamptic on whom a section is done, standard practice of taking the oxygen saturation along with the pulse and blood pressure. We've all done it in COVID, but continuing that and measuring the SpO2 of the patient bedside, especially on the first and the second day, and documenting it is also good practice in a severe preeclamptic.
Yeah.
You don't want the saturation to fall.
So right from early pregnancy, the prediction, there comes the role of prediction, then comes the role of prevention, giving the low dose aspirin and the high dose calcium. And then of course, your regular antenatal care, the patient is lost to follow. That is the biggest problem here. And of course, the antihypertensives. For severe hypertension, this medical officer is giving tablet Nicardia. Okay. This is 176 by 116. The choice of antihypertensive for severe hypertension is injection labetalol. All of you will agree to me. Injectable labetalol or oral capsule nifedipine. Correct? At once, do you want to say any difference of opinion here?
No, madam, the idea is to use some antihypertensives, whichever is available. Now, initially, all of us used to use alpha methyl dopa, which was not available. So we switched over to labetalol. So be it labetalol or be
But
it
for severe,
nifedipine,
the blood pressure is
even
176 by
Okay.
116.
so you need to repeat this, and if it is not settling with one antihypertensive, add another.
Add
If it's
another.
still not
Okay.
settling down, then go over to injectables. But this is over a period of time after admission. So even if this blood pressure of 176 by 116, if she's not symptomatic, if she doesn't have any aura, if she doesn't have headaches, if her urine albumin is not very high, I would still manage her with antihypertensives, check the blood pressure, and add one more. So this does not necessarily
Dr.
mean
Karthik,
injectable.
she has severe pain in upper abdomen. She has pain in abdomen.
yes.
Okay,
Oh,
she's
yes.
having alarming
So
symptoms.
you need to be more vigilant and start antihypertensive. Add one more.
Perfect.
So it's just a progression: 1, 2, injectable, and delivery. I think that is the logical sequence which was followed.
I think the basics of management of antihypertensives or other management of hypertension, at least not to, leave the blood pressure to more than 110 diastolic, because your vasculature is not adapted. Anytime you can have complications of, severe hypertension. That is what the message here is. Anytime it goes up to
Injectable
100,
labetalol, I feel many of us are not used to it. So
capsule nifedipine.
some other
Capsule nifedipine. That is what I'm saying. In fact, the better oral capsule nifedipine, all of us are so well versed.
Not
It is
sublingual,
the
but
onset of
Not sublingual.
absolutely no. That's I don't have that slide, but I think maybe sometime in other presentation I have. It's a crime, I think, giving. All of us have seen patient collapsing, and some patients people lost also.
Ma'am, but one more thing.
Yeah.
When the patient was delivering and her BP is so high, like above 110, we usually do
We are
a
coming to
DIC
that.
profile.
What precautions? Even before that, the the antenatal prediction, prevention, and even the antihypertensives. Then the preload, when she was being taken for cesarean section, the preload also, we give fast fluids. That also could have been controlled. When the baby is delivered, you have to, whatever oxytocin you are giving, absolute no to methergine, give carbetocin. Maybe even the oxytocin, you give saturated infusion of oxytocin, right, to control the fluid overload. And maybe that is a point where the baby is delivered already.
I think that is
We
a
could have
very
given
valid
Lasix.
point you made, ma'am.
Yes,
that is a very valid point you made, because there is already a fluid overload in the third space in this patient.
Correct.
And if you go on giving more IV fluids pre-op, intra-op, and post-op,
yes,
and urine output is not properly monitored in proportion to what you are giving, then it can precipitate such a situation.
Correct.
So urine output monitoring, input monitoring, and if the output is not proportionate, then give Lasix to this patient post-delivery at the earliest. That is a better option.
Correct. And
That
also
can
all of
prevent
you
such
that,
a complication.
Yes. Also, that third stage is the one which gives you maximum venous return and puts the heart on load.
Exactly.
So that is also the time where you give, Lasix. So everywhere after the delivery of the baby, Lasix was indicated, which was not given. Correct. So these are the very situations which has, place the patient at risk. And that is how, so this patient could be managed well. And after 1 hour, she came to spontaneous respiration. And that is why we just tried to introspect where we were wrong and what was missed. So I think that is a good discussion with.
So at our best, the best thing that we can do to the patient whenever we feel that she is high risk and cannot be treated at our center, please stabilize the patient, send in cardiac ambulance to the ICU. That's the best place that she can be.
Yes. So,
Madam, I would like to suggest Maxel, given when she visited first, when she was already in severe preeclampsia. She had BP of 176, 110. She already had edema, abdominal pain.
116. That is why I'm saying
117.
High diastolic blood pressure. She could have thrown convergence.
Kritika, but generally, I think we start Maxel when we are only about to deliver.
Yes.
But that would
once
have
we have
taken
decided
care
for
of
delivery, whether it's a cesarean or induction, that is when we generally start Maxelf in these patients for prevention of eclampsia, and also if it is preterm, then for the brain.
And once we
So
start
Rajendra,
with
you can
maximum,
take
we have to deliver.
Neurological dysfunction prevention. Yeah.
Yeah.
I think let's move on to the next case because there are a lot of cases to be discussed.
Yes, yes. We have very interesting cases. Please, stay tuned. Yes, Rajendra, you go ahead, please.
Okay, so now moving on to the next case, case 3. This is Mrs. XYZ, 20-year-old primey, 9 months, referred at 11 p.m. Once again at 11 p.m. with history of admission at a nearby nursing home. She was admitted there at 3 p.m. with history of strong labor pains at that point of time. And then as there was failure to progress, she was posted for cesarean section. Bladder was catheterized, but there was no urine output. And so that is why she was referred to the higher center, where she reached at about 11 o'clock. Patient on examination is having severe pain in abdomen. Pulse is 110 per minute and blood pressure is 110/70. Strong contractions, very severe in intensity. Fetal heart rate is around 100 to 120. That means there is bradycardia. So now what is your diagnosis? Dr. Sargam is not joined. So let me ask Dr. Navneet, would you comment on this case?
So this is definitely prolonged labor. And somehow I can't read it properly. I'm sorry. I'm actually logged in from my phone. Yeah. So she was posted for cesarean.
She's got severe contractions, strong contractions, and there is no urine output when she was catheterized.
And there is bradycardia.
Yes, fetal bradycardia.
So it looks like a rupture.
Yeah, actually, I think I missed that. The dilatation was only 3 centimeter and there was little blood tinge discharge. Yeah.
Because that was not mentioned. So I was wondering where,
No, it was there in the questions slides I have provided, but here I think. Yeah, please go ahead.
Yeah, so it mostly looks like a rupture uterus with bladder injury, where
with the contractions plus with severe intensity. Now also there is no relaxation in between. That is what it is mentioned. Uterine contraction plus of severe intensity even now.
So it might be persistent occipital posterior also.
It could be a prolonged labor.
This could be abruptio placenta also.
Yeah.
Yes, that is what.
Was the catheter in the proper place?
Okay, go ahead.
But then bleeding was only slight, sir. So abruption. Okay.
So I would just give you some history also with this patient. When their sister tried to catheterize this patient, the bladder was catheterized, but there was no urine. And when retrospectively they asked the history, throughout the day she has not passed urine.
Okay, so then it goes more into a shock kind of thing with hypovolemic shock.
Abruption.
So it could be abruption. Yes.
Yes. So the investigation was done. Ultrasonography was suggestive of abruptio, and hemoglobin was 8 gram%, platelets 1 lakh only. Hepatitis was prolonged and
Pranita, you can unmute yourself and directly answer because she was answering in the chat box.
Okay, who?
Dr. Pranita.
Acha, Dr. Pranita.
You can,
Try to listen to you, my dear. You can take up this case. FDP was present and fibrinogen was 150 milligram%. So this is what the investigation report. Quickly, whatever we could get. So what is your diagnosis?
So diagnosis is abruption, and we stabilize the patient. Vitals are still stable. Fetal heart is there. So an urgent delivery. What was the dilatation, madam?
Dilatation is only 3 centimeter and membranes
so urgent delivery,
having some brownish altered blood. Okay.
Yeah. So it is probably a concealed kind
once
of,
again, I place a question whether you would like to, because it's a fetal distress. So whether you would like to take her up for cesarean section first or you would like to manage her first. Whether this patient needs some management before taking her up for cesarean section or any operative procedure for that matter. These are the investigations I've given you here.
Madam, with prolonged APTT, FDP present, fibrinogen coming down to half of the or less than half of the predicted value in the 3rd trimester. So 150, she is into impending DIC or she has just gone into DIC.
Yes.
So stabilization is most important before you take the patient for LSCS for delivery, or you try to deliver vaginally, whatever way you want to go.
Mhm.
So blood and blood products, and the first thing you should give the patient is tranexamic acid 1 gram IV,
Perfect.
and
Yes.
you can repeat it after half an hour. Another dose of tranexamic acid, 2 grams you can give safely to the patient, and you should immediately start with pack cell transfusion along with fresh frozen plasma for the patient. So,
Yes.
and with platelets
Yeah.
ready the backup.
Yeah, I think the first thing is to deliver the patient, because unless you deliver, you are not going to reverse the pathology. So unless you deliver,
starting all this, you
my
can take the
question is,
patient up.
once you are sure, once you are sure that the blood bank will give you blood and blood product, the next moment
then first
Yeah.
thing is deliver.
Yes.
The other thing is, madam, you will have
we
to
will
monitor the
reserve-
patient's liver profile and renal profile also.
Yes.
Because she has not passed urine since morning, she could already be in renal shock. So you'll have to hydrate the patient adequately and give a Lasix challenge, and
Yes.
then take a call from there. And you may have to transfer the patient immediately after delivery, cesarean or otherwise, to an ICU for further
Yes.
management.
Yes. So you can see, so it's all these are the complications. This patient, she has hypovolemia. The BP is deceiving. I'm sure you all of you thought 110/70. The BP is deceiving you. It is hypovolemia and the reversible renal failure probably, and that is why there is a need to resuscitate. So
So
aggressive fluid.
basically, it's an abruption which has been missed. So she's
Yes.
having a blood clot since a very long time, all concealed, and that
Yeah.
is why now she's exhausted the clotting factors.
Correct.
So
Because
that
The
is why
typical
you
case
have to
of
be very
consumption coagulopathy.
Yes. Because it is concealed, it is missed, and that's the reason she has gone into DIC earlier. So abruption delivery interval is very, very important. Baby is already in distress, so you are taking her for operative procedure. What precautions you would like to take for this patient, even intraoperatively and post-operatively? So before that, I would just say, when you're giving aggressive fluid resuscitation, is it only the volume or what else you are looking at?
Blood components also should be.
Yes, Pranit. Yeah.
Some blood components also should be given, whatever blood is available.
So fluids, IV fluids, blood components, blood and blood products, whatever, and you have to look for the, not only the.
How would you decide which component you want to give? Like, what do you give when for the low fibrinogen? What would you, how would you decide whether you want to give her FFP or whether you want platelets, or whether you want to give her cryoprecipitate? How would you decide?
Whenever you are suspecting that there is a consumptive coagulopathy which is already set in, then it is the best idea to give cryoprecipitate, and the fibrinogen level is also low. So cryoprecipitate has a high concentration of fibrinogen, also the less volume per se. So you're not
Correct. So whenever the
overloading the
low
patient.
fibrinogen, you have to give cryoprecipitate. Okay, and
at this juncture, it is better to use fresh frozen plasma because it contains fibrinogen and the
all other clotting
coagulation
factors.
So here you are dealing with not just blood loss, you are dealing with a consumption coagulant. So all the coagulation factors have also been used. So at this juncture, probably fresh frozen plasma would be of use, of better use. And then, over a period of time, if with massive hemorrhage or later on, you can always use cryoprecipitate. So cryoprecipitate contains more of fibrinogen, but fresh frozen plasma will contain fibrinogen plus the coagulation factors. So that probably
should be a 1:1 ratio of
and 1:1 ratio.
Yeah.
So I feel at this time it will be better to involve one hematologist into this, asking and then giving because it is again
the
a very
intensivist has to be
tricky
there.
situation.
The intensivist has to be there, and
Yes.
a hematologist also.
Hematologist. Yes. Okay. So what is your optimum points? What all things the target you are looking at to stabilize this patient?
So most important ones, it is an APH. She can always land with a postpartum hemorrhage. So we should look out for that. We should give her uterotonics to prevent that, along with restoration of her volume, whatever
So what
is
uterotonics
lost,
for
blood
this patient?
components.
What uterotonic you will prefer for this patient?
Ma'am, I normally oxytocin or carbetocin along with your misoprostol.
Okay.
And methotrexate.
prostaglandins.
Prostaglandins. Prostaglandins again, sir, because we don't know the detailed history of asthma and other things. So,
TGF, 2-alpha, IM injections we could avoid because it can cause further hematoma.
yeah, and again, intramuscular injections of prostaglandin with platelets and other things is a problem. So, misoprostol will be better. Along with, you can give metharsine if needed, IV.
No, she's hypertensive. So
She's hypertensive. This is yeah. The BP was
Carbetocin and concentrated oxytocin infusion. I think that's on priority.
Because for preventing PPH, we can always use carbetocin.
And then definitely once she lands up into PPH, you don't have any option but to use even the carboprostate injection.
Yes.
Because that point of time you have to manage PPH priority. So it is not very hard and fast, but because she is hypertensive, try and avoid all these drugs. So definitely you're looking at to stabilize her, the blood pressure should be at least 90, and the hematocrit should be maintained to 30%, urine output at least 30 ml per hour. So that is how you are already just trying to stabilize this patient. So we have discussed about what fluids and what blood and blood components. Massive transfusion protocol is actually totally different. That will take one more panel discussion, but we just move ahead to the
sometimes I can just add, sometimes in a typical cuvalier uterus with significant PPH, we may even have to do a hysterectomy in this situation.
For cuvalier uterus, we don't need.
Usually don't need hysterectomy.
If there is PPH, there is.
In fact, Rajendra, in fact, the message will be like it is a self-resolving condition. If a patient is not bleeding, it is not.
I said if there is massive PPH, if there is PPH because of only then, because that is one uterus which is not going to contract very easily.
And now I think everyone will be very confident because Saraogi sir has so nicely, beautifully talked about
that's what I said.
Hysterectomy. So everyone will be very confident doing it.
Yes. So Dr. Navneet, we coming to you.
Yes.
We had this 32-year-old para one previous cesarean section. She has male child only 1 year old. And now she has come to you as bleeding per vaginum during 6 months of pregnancy. Okay. And she has come to you for the first time because of the transfer of her husband's job. On further inquiry, she gives you a history of early pregnancy spotting, and she does have an ultrasonography report suggestive of low-lying placenta. Now, obviously, she has bled when she visited you, so you do her ultrasound. 26 weeks, no anomalies, placenta previa, absent RP leg. This patient comes to you again at 30 weeks with history of bleeding, started at home, but stopped again when she reaches the hospital. So you send her for investigation, and within no time, she collapses in front of you, starts bleeding profusely. So what is your diagnosis at this point of time, and how would you manage this patient? Emergency management, we talk about this first. Then
Madam, this looks like a case of placenta previa.
Previa and anything else? Absent like the sonolucent, retroplacental sonolucent zone is missing. Does it tell you something?
Accreta spectrum.
It can be accreta.
Yes. So it is a morbidly adherent placenta or placenta spectrum. So now you can discuss the diagnosis.
Madam, probably the placenta accreta may not bleed.
It will not bleed.
Yes, Dr. Karthik, if it is a patchy adherence, it will bleed profusely. Yes.
It can be vasa previa also.
Vasa previa doesn't bleed so profusely that the patient collapses. It exsanguinates the fetus. Okay, so who is discussing, Dr. Navneet?
Yes, ma'am. So first thing is you have to manage the patient's ABC, that is resuscitation. You have to put in a wide bore IV line, start with oxygen, start with fluids, stabilize the patient, catheterize the patient, then see for her fetal heart rate.
Call for help. I think we
call for help. Yes.
For common it will be because all are near miss, very emergency cases. Okay.
Yes. Arrange blood. Get a sonography done again for what is there inside now, and then start with the stabilizing the patient. Then you plan how to deliver the patient.
Okay, but this patient who is bleeding, do you think that she will get stabilized? She's collapsed. She's bleeding profusely. Okay. So, yeah, you try and resuscitate her on
Resuscitate,
one hand,
yes.
and you arrange for everything on the other hand. That means your team will work for you.
Yes, yes.
So
Forest
what
is there, yes. And you deliver the patient.
whom do you want in your team, and how would you counsel the relatives that what are you going to do with this patient now?
So, ma'am, as it was mentioned in the
I'm sure
last
all of you are
phonograph.
doing this. We are just discussing it. All of you are doing this, I think, routinely in your practice, or maybe in the medical colleges also. But just to discuss the case, I think, yes, Dr. Navneet.
So, madam, I will tell the patient it is a case of placenta accreta. Mostly it must be adherent inside, and there is high chances we cannot remove it. There is high probability we'll end up doing a hysterectomy for the patient. So we will counsel accordingly, and in our team we need when we are calling for help, we will call the anesthetist, another gynecologist to help you with a surgeon and someone who's expert into devascularization and maybe an oncosurgeon or someone like that.
So you need a senior obstetrician who is experienced, or maybe a junior who is expert. Okay.
Yes,
so obstetrician, anesthetist, preferably senior, or maybe 2 anesthetists, and then maybe physician or intensivist. Who else do you want for this patient? Neonatologist, naturally, for the baby with NICU setup. Who else you want for this patient? Whether you want surgeon,
surgeon, maybe a surgeon,
maybe a urosurgeon,
because it is a surgeon, a neurosurgeon, or any surgeon preferably. Because
somebody who is well versed with doing internal ligations, or even difficult cases in terms of surgery.
Because you don't know where the accreta has gone.
You may need to stent the ureters. If it is accreta, the dissection becomes difficult. Maybe you make a trauma to or injury to the bladder. Sometimes, you have to dissect. They say that you do deliberate cystostomy also. Okay, for this placenta percreta cases, you may have to go for it. If at all you cannot remove the placenta and separate from the lower segment also. So that is how. So surgeon, and who else? The blood and blood bank, you said.
Yes.
Whether you would like to have interventional radiologist, if facilities available.
If needed, in our kind of setup, no, but yes, in a tertiary care center, yes, we will need it. For a backup, at least we'll inform them and keep. Suppose the bleeding doesn't stop, then we may have to do a.
In fact, Dr. Navneet, I would appreciate your message saying that once the patient is diagnosed with placenta previa accreta, we dare not, admit her in the
smaller center,
smaller nursing homes, individual nursing. She has to be registered or transferred to the, tertiary care setup where you have multidisciplinary approach, right?
Right.
It is, in fact, very well delivered. And now we come to the proper management, that what precautions, now you have taken the informed consent, you have told them that maybe she may land up into the obstetric hysterectomy, maybe she land up into, so much of injury to bladder, this, that, and maybe she may be moribund, she may receive multiple blood transfusions, and she may land up into reactions due to blood transfusions, maybe dilution, coagulopathy, and whatnot. Okay, so in spite of everything, but we have to take, and to save the patient, we may have to go for obstetric hysterectomy. Rather, we have to go, you take a consent this way. Now, when you start operating, what precautions you take for this patient? I think Dr. Karthik, and who else?
Dr. Belvi has not spoken much.
Dr. Belvi, yes, that is
good evening. Good evening.
The panel.
So, this is the known case of a placenta previa at 30 weeks with a diagnosis of an accreta also. So it's going to be a very dramatic scenario on table. Apart from all the requirement of the team and the blood products, everything that is mentioned, I think the threshold to do an obstetric hysterectomy should be quite low. Once you are sure that you deliver the baby and you are not able to separate the placenta, the decision to proceed with an obstetric hysterectomy.
I'm sorry, I interrupt you here. I think we need to take some special precautions before starting the operative procedure. So whether you would like to comment on the incision, the abdominal incision, the uterine incision? Yes.
So abdominal incision vertical, uterine incision vertical.
Okay.
Classical.
Just
Definitely.
short of the placenta. You need to map the placenta once again if possible. Or maybe you just short of the placenta, short of the lower
Yeah.
segment.
Try and avoid the placenta as much as possible. Deliver the baby, and then I think the management is quite certain that if it is
Don't be in a hurry to separate the placenta.
don't be in a hurry to
The
separate the
message is,
placenta. Yeah.
that is what the message is. In fact, I would say absolutely no attempt to separate the placenta. If it is, just wait for whether it is separating on its own. Sometimes the diagnosis can be wrong. That is a different issue. But when you are sure of the diagnosis, I mean, absolutely no attempt to separate the placenta. And of course, as you were saying, that it is like a elective obstetric hysterectomy. You have to tell the relatives beforehand that otherwise it will be reflected badly on you, that you have landed up into some complications, that during the surgery you have to take a consent for obstetric hysterectomy. And that is what the message here is. Secondly, I think I would like one of you to comment on the uterine conservative surgery, which, people are not only talking about it, even maybe around 3 years back, I myself used to tell that, when you have such patients, it should be a planned obstetric hysterectomy. It should be posted in the early hours of the day, and when all the seniors are around, everything is arranged well. But now the concept is changing because people have succeeded, hundreds of cases they are doing. So anybody to talk on the uterine conservative surgery for PAS?
Probably, uterine conservative surgery can be attempted if the placental adhesion is partial. I think with a complete large placental area, the reconstruction of the uterus may be difficult. So if there is a smaller area of adhesion, you can take out that area along with the uterine wall and suture it back. And that becomes a reconstructive surgery, provided it has not eroded into the other organs. So I think it all depends on the area of adhesions and what you actually find. So there is a definite place for reconstructive surgery, but all this is best mapped earlier. So in this case, adhesion was missed earlier, and if you had thought of an adherent placenta, you would have mapped it properly. Probably an MRI could have helped you in that case, and then you would have been in a better position to do it. One advice or the take-home message would be: if you are unprepared, you've taken a patient for cesarean section, and on table, when you open the abdomen, you find that the lower segment is so vascular that it's going to be very, very difficult to manage it. Close the patient and send her to a tertiary center. So don't be adventurous and do the surgery and land up in severe problems.
That's a very valid point. Very important take-home message for small nursing homes, that if you feel that you cannot do it at your setup, especially when there's a possibility of a PAS syndrome, then you have to decide and close the abdomen and shift. Unless you've already discussed it and taken her to a center where there's facility of uterine artery embolization, etc., because there are a lot of comments coming from the chat box also that she should undergo uterine artery ligation, uterine artery coil.
So So actually, Rajendra, on the continuation with the same point, that if you are aware of everything and if you are well prepared for the elective procedure, then you can give a thought of what is called as P procedure, that placental mapping, as Dr. Karthik said, with the MRI, and then of course stepwise devascularization, stepwise pelvic devascularization, then what is called as patchy resection of the myometrium. So that is what is the P procedure. But recently, what over last 3 to 5 years people are doing, even in Delhi and even in Gujarat, we have just heard few of the talks. Not only that, they have a series of hundreds of cases where they actually do stepwise devascularization even in emergency, and they actually remove, they scratch out all the placenta. They see to it that really, we have seen the videos also. That is AMOGS MG stitch, what Dr. Saraugi and all of us were discussing during the talk also.
Mahesh Gupta.
So at the Mahesh Gupta, AMOGS MG is Mahesh Gupta stitch. and that is how that he has a curved needle and a straight needle, and how you have to take at the cervicoischemic region, the uterine and the descending cervical, both the vessels, and the blood flow is significantly reduced. And actually, he has showed many cases, intraoperative, unedited videos also. Recently, we had a workshop at Patna also, PPH conclave. So, the things are evolving, and there are now hundreds of cases which are being managed conservatively. And there are people who are following this and becoming successful. So it is only for the elective cases. Our patient has collapsed here. So for this case, it is not a discussion. Definitely, it is a obstetric hysterectomy. So that is what. Now that we have managed this patient, everything, but just to introspect ourselves, was it preventable, Dr. Dhaval?
Was the hemorrhage preventable, or was the
right from the beginning, when you diagnosed, this patient was diagnosed as having placenta previa and accreta at 26 weeks. Before that also, she has had warning hemorrhages earlier. Okay, so
it's a very natural phenomenon. The previa is a very naturally implanted placenta in the lower segment, and the fact that she's developed an accreta is purely because of the previous section scar.
Yeah. So it's not, we are not talking about the accreta preventable. We are talking about the catastrophes, whether it was preventable. That means at 30 weeks, could we have been, able to take this pregnancy ahead up to 34 weeks? The question is, of course, it is only for discussion whether prophylactic cause tightening, any role of tocolytics.
No role.
Okay. Once absolutely no. That is what
antenatal steroids will have a role. Antenatal steroids should be given after 28 weeks in such patients.
Perfect. So even after 24 weeks, you give antenatal steroids and magnesium sulfate when the delivery is imminent, or just you feel that she may bleed now, and that is why the transvaginal sonography with cervical length, because it gives you prediction for the earlier separation and earlier bleeding also. So that is what about the role of ultrasound also. But the obstetrician who is diagnosed has, whether she had advised what precautions she has to take, being a placenta previa, when she was diagnosed and confirmed at 26 weeks, she was sent home, and then she came to her hospital at 30 weeks, and then she collapsed. So we had lots of window of opportunity to educate her, to monitor her, to hospitalize, and maybe we could have taken her to at least 34 weeks.
The key message here is you diagnose early, or register them in a tertiary care center, and you could be the conduit.
Important thing is the suspicion. So when there is a previous LSCS and an anterior low-lying placenta, you have to preferably do a good sonography, or at least an MRI, to rule out that possibility of an adherent placenta. I mean, a morbidly adherent placenta.
Yeah, and the message here is, it is if you have a good sonography machine with good resolution and an expert sonologist, the results with MRI are absolutely comparable. Only in case of the placenta previa and a morbidly obese lady only, I think there is a role for MRI. And as we discussed that while mapping the placental depth of invasion, the role of MRI. So this is what the RCOG guidelines, that at 16 weeks you label her if it is within 2 centimeters. Keep a watch that it is low lying. Maybe when it is actually previa, you label it. When there is no sonolucent zone retroplacental, you label it as accreta, and it shouldn't be accepted in the smaller nursing home. This is what, when 11 to 13 weeks also, you can get an idea about this placenta accreta spectrum. But at you make a routine that at anomaly scan, you have to look for the localization as well as the this retroplacental sonolucent zone, where you can diagnose and label this patient as having placenta accreta spectrum. So definitely all this management we have already discussed. This is all the theoretical discussion, but what are the special precautions, that also we have discussed intraoperative, preoperatively. So how to manage coagulopathy, I've said that it will be another panel discussion. So we have lots of things to discuss, but I will not now go into this. I'll just simple message. I think we will not take this case but I will just place in front of you. What is it? Dr. Sargam is not here, but anybody can. You have this grand multipara admitted to emergency ward late night, and with obstructed labor, and her pulse rate is 110, BP is 130/80, maternal exhaustion, and she is thick meconium stained liquor. So with antibiotic cover and fluid resuscitation, she was taken for cesarean section. 4 kg distressed baby was delivered. There was a little extension of the uterine incision, but that was taken care well. There was no intraoperative and postoperative significant bleeding. This patient was shifted to ward comfortably stable. But suddenly after 1 hour, the patient became restless, disoriented, confused, with a vomiting tendency. Her blood pressure was 80. There's no bleeding outside. Abdomen is soft. What is your diagnosis? Actually, this case is only to give message. We'll wind up the panel discussion. I think.
Probably a broad ligament hematoma.
It looks like a hypovolemic shock kind of thing.
There is no pallor.
There is no pallor. That is what it is mentioned. And uterus is well contracted.
Contracted, yes.
Hypovolemic shock kind of. Yeah.
Hypovolemic shock because the patient was in prolonged labor for a long time with maternal exhaustion.
I have just mentioned here, see, you can see fluid resuscitation. After antibiotic cover and fluid resuscitation, she was taken. So the preload was good.
Yes.
Was it anaphylaxis?
1 hour after cesarean section, when the patient was comfortable, then that time no drug was given. I would just say this is a non-hemorrhagic shock. Okay.
Yeah, so non-hemorrhagic.
Okay, so how do you manage?
So, ma'am, basically fluid resuscitation again, because the BP is only 80.
But what fluid you want to give her?
Is this an amniotic fluid embolism?
So we say that amniotic embolism is a diagnosis of exclusion, right, Dr. Dhaval?
Yes, you do.
So I think we have to think of something which we can manage. You are right that, but then once that patient, once we rule out everything, I would just say it is a non-hemorrhagic, very simple case.
Is it a septic shock because of obstructed labor for a long time?
But again, antibiotics were given.
No.
Yeah, but that cannot.
Yeah, you're right, but it is not so.
Not in 1 hour, septic shock will not happen.
1 hour.
That is why. That is why. Because it's the case only over the period of whatever 12 hours, no? The labor and the
cardiogenic shock.
It could be hyponatremia or something like that, but then why the BP will go down?
Okay.
Hypoglycemia.
Should I reveal it?
Cardiomyopathy.
Very simple bedside investigation, blood sugar.
Oh my God, ketosis.
Sugar. So urine gave us the diagnosis. Okay.
But
your blood pressure was not diabetic previously.
Your blood pressure of 80 is confusing us.
The blood pressure of 80 is confusing.
Yeah, but diabetic ketoacidosis.
But why would it develop so early, unless and until a patient is frank diabetic?
The baby was 4 kilos.
But then again, it was exhaustion, prolonged exhaustion.
But blood pressure.
So that means the patient was diabetic early.
Also.
That is the message we want to give. That is the message we want to give. We are not discussing this case. Diabetic ketoacidosis, our physician friend will manage.
Yes.
The message here is universal screening for hyperglycemia in pregnancy at the first antenatal visit and 24 to 28 weeks. So whether it is a overt diabetes, whether it is a GDM, we must go for universal screening because that is the only thing. Otherwise, we have all of you know everything. So the take-home message for our panel discussion is every obstetric unit and every person of the obstetric team must be trained and skilled to manage the maternal collapse. There's no time for immediate referral. In fact, referral in the unsettled condition may worsen the situation due to multiple issues. And I'm sure all of you know that, if the patient dies on the way, that is a crime. We are not allowed to perform that. So the team should manage effectively then and there only. And for this, we should have an efficient multidisciplinary team, not only HDU. So HDA, the Supreme Court always says that every obstetric unit should have an obstetric HDU or ICU. This doesn't hold true, but at least we should be trained to tackle with this,
manage such cases.
Yeah. So I think these were the common cases which all of us face, and it was wonderful having all of your inputs here. And I thank all the experienced people, Dr. Karthik, Dr. Rakesh, Dr. Ujjwala, Navneet, and of course, I hope I have not missed anybody, Dr. Belavi. So I thank all of you for contributing to this, and my dear friend, Dr. Rajendra, who accepted to be the panel moderator with me and who has taken a lot of pains to coordinate this program. I have already thanked you, Rajendra. Your planning and execution, everything Rajendra has helped me, and I'm very happy that all of you have joined actively for this panel discussion. It was wonderful to be associated with you. I can see my guide mentor, Dr. Suchitra Pandit Madam, also here, who has seen me working since 2003. I promise you, Madam, I keep working hard even further. And I just make an humble appeal to all of you that please do support my candidature as FOXI Vice President for the upcoming elections. I'm contesting from West Zone, so please do support and vote for me.
Thank you very much.
Thank you, ma'am, and all the best.
for inviting you.
Thank you, ma'am. Thank you for
Best wishes,
inviting, and all the
best
very
wishes,
best.
Sneha, for your
the best.
elections, and definitely you will be there. Definitely this time, no doubt about it. We are
Thank you.
all with you, and yes, I can say that confidently.
Thank you so much. Thank you.
Thank you, madam. Best of
Thank you
luck.
very much
Thank you.
for selecting very interesting cases.
Dr. Ujjwala, Dr. Pranita, and I thank my dear friend Dr. Monica Umbardan and Dr. Madan Kamble also for conducting the event flawlessly. Thank you so much.
Thank you so much, ma'am, for the opportunity to coordinate. Thank you, Rajendra Nagarkati sir, for coordinating the entire program with us and helping us with the names and the contact details. Thank you, Saraugi sir and PK Shah sir, for being the chief guest, and Dr. Niranjan Shah, Bipin sir, and Rajkumar sir for being the guest of honor. I would like to thank Suchitra madam for being so supportive that she's always there for us. Thank you so much, all the panelists and our chairpersons for today, Dr. Manohar sir, Mohan sir, Karthik sir, and Komal Chavan madam. Thank you so much. Thank you, Sahiti, for the technical help.
Thank you, ma'am.
Thank you so much. Thank you, Dr. Karthik. It was a pleasure to have you for our the